Good evening, everyone. Welcome to this meeting of the Health and Social Care Overview and Scrutiny Committee. We've had apologies tonight from the chairperson and vice chairperson, so the first thing members need to do is to elect a chair for the meeting. So if I could ask for nominations, please.
I nominate Councillor Llewellyn-Printer to chair the meeting.
And is that seconded? Are there any other nominations? No.
Agreed.
Okay, it's Councillor Llewellyn-Printer in the chair for tonight.
Welcome members, good evening and welcome to the Health and Adult Social Care Overview and Scrutiny Committee. Can I ask first of all for any apologies for absence?
Apologies from Dan MacDonald.
Thank you.
And apologies from Satinder Shokar.
Thanks very much. Anyone else? So we're going to adopt the record of the last meeting unless anyone has anything to say on that. Otherwise, we agreed. There's two sets of minutes, apologies, the 22nd of August and the 20th of September. All agreed? There are no urgent matters to announce. Does anyone have any disclosable pecuniary interests or other significant interests and whipping? Councillor Hamandashi.
Yes, I shall be stepping out for item 7. I'm an employer of the trust.
Thank you, Councillor Hamandashi. Moving on to the first item, which is the annual complaints and compliments report, 1st of April 22 to the 31st of March 2023. Welcome Sandy Weaver to introduce this item.
Thank you. You have to bear with me as I'm a slightly, well, not slightly, quite hard of hearing, so sometimes I might ask you to repeat questions you ask. Just very briefly, there were 85 complaints received in this annual report in this year. 63 were from frontline services. Good news is we had the highest percentage of complaints answered in time ever. I've been doing the job for 10 years, ever in my time. I have got stats back there. There was an increase in complaints re communication difficulties, which is a shame because that slipped and had improved in the last 2 years. There was a theme in delays in providing services and reviews. I think post-COVID there were a lot of difficulties in finding placements. Another good news is this year we had 30 compliments compared with 20 last year. So open now for you to ask questions.
Any members? Start off the questions for Sandy. Councillor Campbell.
Hi. Can you hear me?
Yes, thank you.
Yeah. Thank you for that update. I was just unclear what locality 1, locality 2, locality 3 are listed in the complaints, because I think locality 1 has the maximum number of complaints. I just wondered if there was any insight.
Do you want to answer?
Thank you. Yeah. Adult social care works in locality areas. The reason for the highest number of complaints in locality 1 is usually because it's where the largest number of care providers are. So it's where the care homes are. It's also where the acute trust is. So actually the demand in locality 1 is much greater for the number of people that they support, which is why we see the level of complaints being higher.
Councillor Wildey.
Thank you. Can you tell me this number of complaints and compliments out of how many contacts do you have total? Just a rough number, because it does seem that to put it in context, that's all.
So with regard to the number of people we support, we've got approximately just under 3,000, so about 2,900 people that are receiving care and support in Medway in the form of a care package or in a residential care home. And then there's around about another 2,500 people that we support from, say, carers. So you're looking at a sort of a round figure of about 5,000.
Councillor Prenter.
There's a positive increase in compliments received from previous years. A number of complaints were upheld resulting from the lack of poor communication. What improvements are planned or being made to improve this process?
Okay, thank you. So one of the reasons for lack of communication is actually because of the number of staff we have. So there is a real challenge with resource. If you look at the number of vacancies we have that are filled by locums, that's significant. So we were at around 60% locums for our frontline social workers. So there's a level of social workers. And obviously that creates some flux in the system because we see people move in and out. So it's that consistency that we need. At the moment, we're doing a piece of work nearly completed to look at actually to enable us to be fully resourced. What does that social worker workforce look like? And then we want to move to what we call an allocated worker model. So if you talk about children's social care, you have a social worker that works with an individual. We don't have that in adults at the moment because we don't have the resource, and that's something we want to move to. So that's all taking place at the moment as part of our improvement journey, being sort of supported by Leanne and Teresa. To look at then, if we get to a place then where actually where we've got the right staff, we'll be able to communicate much better.
Do you want to come back in, Councillor Prenter?
Yeah, thank you for that. It's just another question, I'm taking liberties a bit. There's a lot of complaints on finance. There's quite a few complaints on finance. Is that just about billing? Because I've had experience of a bill that I actually paid, that then I got sent another bill and another bill and another bill, and then threatening bills? It was just something had gone wrong in the system, or is it more in depth than that? Is there more fraud or things like that? What is that finance? Because it is a bit worrying seeing so many finance complaints.
So there is a mix. So some of it will be specifically around billing and, you know, sending out information that might be incorrect. So an example may be that we charge somebody for care that they don't actually receive, but we've not been informed by the care provider, the home care provider, that they didn't receive the care that day. So the invoice goes out and then we have to rectify it afterwards. And if we're not informed in a timely manner, then that can lead to the invoices going out repeatedly incorrectly. And we're about to start work on implementing a system called a provider portal, and that means our care providers will be able to uplift the actual care that they provide to our residents so that we can make sure that we're billing correctly. But other elements of that will be around financial assessments. So when the financial assessment to look at how much someone is charged for the cost of their care takes place, sometimes there can be complaints around that because the information we've been given may not have been accurate, or we've, you know, incorrectly carried out the financial assessment. So there's a different number of things.
Councillor Cook.
Yeah, thank you very much for the report. I found the data particularly helpful in terms of looking at trends. I wanted to ask particularly about the 7 upheld complaints, and I was just interested to know how the settlement figures are worked out. Is there a particular rubric that we use? Is there a framework? How is the amount given decided? Thank you.
Okay. Some of it will depend on the level of what the level of the complaint is. So an example being recently we've had to do give a recompense because the Ombudsman had found a case where a person in a residential care home had been charged inappropriately for their care. Now, that took a long amount of work to actually understand what they'd been charged for. So you then look at the level of charges that have been applied to the individual and look at a percentage of that to see whether you know that refund will support them, or not the refund and the additional money will support them. So it's not a framework as such. It's down to what's individually happened in the complaint. I mean, those ones that have been upheld specifically, but there will be ones sometimes where actually we can see that, you know, we've made a mistake. You know, it's very, very clear. Human error has been made, but it's caused a lot of distress. And in those circumstances, we'll look at those cases specifically as well.
Did you want to come back in, Councillor Cook?
Yeah, thank you. So I'm really curious to know how we kind of decide an amount that goes to an amount of distress. Is there a kind of standard amount we tend to give for a certain amount of distress? How do we kind of get proportionality?
If I can answer that one, one has to look at what injustice has occurred. I'm talking in the Ombudsman's language, but it's easier to understand. We can make a mistake, but it didn't cause injustice. For instance, in schools or something, they got a place in a school, the child didn't have an injustice of no placement, but it wasn't the school they wanted, maybe. But if it is looking at how much distress did this cause the person, how much time and there's various categories, time and trouble to make a complaint, that can take a lot of time. And I know I've made a few complaints, it took up quite a bit of time. How much injustice there was, and a financial remedy is usually when we can't put them back into place. We can't make it right for them. So we're going to remedy that by financial remedy. And that could be anything, and the Ombudsman used to suggest, say, £300, but the Ombudsman are giving higher financial remedies recommendations at the moment. But as I say, one of the remedies I gave to someone was they wanted some flowers. It's not just financial, it's just how can you make this person feel that we've listened to them and we've remedied it in some way for them. And each case is very individual. The Ombudsman might even in one of those cases say, we were at fault, there was no injustice, therefore there's no remedy to be given out. It's very much just trying to look at the unique and individual situation. no easy guidance.
Councillor Campbell?
Thank you, Chair. Thanks for allowing me a second question.
So we know actually that the number of people we support from ethnic backgrounds is lower than it should be. And some of that is to do with families' pride and actually wanting to support themselves. So we know that there are people that we class as hard to reach groups. And that is something that we need to look at and we need to work on. And working with James around the JSNA and what's occurring in Medway. It's one of our areas for improvement. So I think with regard to the numbers, they will be lower because the number of people that we support are lower. So part of our CQC assurance and assessment of adult social care that's coming is actually looking at, do we reach those hard, so do we support those hard to reach people? Do we support people where there are barriers? What are those barriers? And that's one of our key tasks going forward, to look at that piece of work and determine actually how do we reach out to people. We know, for example, that we've got MACA, we've got so the Medway Afro-Caribbean Society that we can work with, but we've got to look at other ethnic groups to see how we can support people going forward so that we make this adult social care much more open and accessible to people.
Councillor Hamadashi and then Councillor.
Oh, thank you very much for the report, and my colleague stole my thunder on that one. Actually, I was going to say the same thing. But in relation to the comparison of the year-on-year complaints, right, year by year, have you got any data pre-COVID? Because I can see that there was a general trend from 2019 to 20, where it was kind of higher, like from 2018, 112, then 117, then it started to tail off and start getting lower. Do you have any data that predates like COVID, like 2018, 17, 16?
I do, but unfortunately not on me right now. One wouldn't have access to it right now. I do know that the figures have come down. They've steadily come down in that period before COVID from, I think the maximum we had was 123. I'm going by memory, please don't quote me. So they've come down from being in the hundreds to where they are now. So there's been, with a few rises and bumps, a steady decrease. But it's not they're very small statistics. So it's not a major decrease. I think we would be worried if we weren't getting complaints, because an organisation needs to value complaints. It tells us where we're not quite getting it right. So I think we've just hit a plateau in the last few years. I don't know whether they'll go up or down, but they've never been more than about 120.
Thank you. Thank you.
Thank you, Chair. I just wanted to comment as well. So the complaints that are coming through are specific to adult social care, as in Medway Council social workers teams. But we do also get complaints if there's an issue about a care provider. So generally speaking, people will go to the provider first and make a complaint. But if they're not happy with that, then they'll come to us. And that's when our commissioning team looks at it and works with the providers to resolve the complaints, or with us to resolve the complaints. So this number is specifically about adult social care, but obviously there are other complaints taking place outside.
Thank you. Anything to add there, Councillor Hamadashi?
No, that's fine, thank you.
Thank you very much. Councillor Gilbourne.
Thank you, Chair. It's just a question on section 5.2 about the timeliness of responses. It says about Medway Council aims to respond within 20 working days, and the percentages seem to be fairly good at how well you do within 20 days. But I just wondered if that figure, how long it's been in effect is 20 days, and whether you actually feel comfortable with that level.
So it would depend. So I mean, we really push hard to reach the 20-day limit. It's something that I really encourage the team to do, because if we can do it before the 20 days, actually it's important for me, because I know what it's like personally when you complain to somebody and you don't receive a response. There are times that we won't meet the 20-day limit because actually we don't think it's achievable, and we'll be providing a response that's not acceptable. So in those circumstances, Sandy's team will write out to people to say, actually, it's going to take longer than the 20 days. And when you look at the data, you'll see on occasions where it dips lower, that will be because we paused that. So we will only ever respond within the 20-day period if we can do it correctly. If not, we'll say we need to hold fire and take a bit longer.
Can I just add to that? Most of those that go over the time scale that we've set are commissioning complaints, and the commissioning team then have to go back to the service provider to provide information. So that takes time, and they can be really complex complaints as well that involve more than one team. May even involve a discharge plan. So those are the sorts of complaints that would go over. And I agree with Jackie. I always say that we need to give a good response that's really, that can try and remedy and resolve the situation. So I think sometimes it's very valid to go over time. In the actual legislation, there's 6 months. And that's because it's health as well, and they have to do clinical reviews. But we wouldn't want somebody to wait that long. So it's a balancing act, but it doesn't worry me so much, as long as it's a good response.
Thank you.
Councillor Anang.
Thank you very much, Chair. I want to follow up from what my councillor, my other colleague said. With regards to the ethnic minority groups, looking from the data and the 2021 census results, it's like the ethnic minority groups don't tend to report. And currently the demography is changing. We are getting more ethnic minority groups moving into Medway. So what are your plans to encourage, maybe because of lack of education, most of the times people from the ethnic minority groups will not know even that there are some mechanism whereby they can report if something goes wrong with the system. So what are your mechanisms that you are putting in place to encourage people from ethnic minority groups to come forward if they face such issues?
So we've actually just last week had a meeting with Health Watch to look at what they can do to support us, because sometimes a statutory service going out to say, actually, can we support you, isn't welcomed. People don't want to come into statutory services. So by getting Health Watch to reach out and actually ask people and say, you know, what can we do to support, how can we encourage you, that then gives us the data and information that we need then to be able to go out and say to people, you know, this is adult social care. If you've got care and support needs, this is how you need to contact us. It's also understanding the groups that are out there. So how do we reach into the ethnic groups? And that's what I was saying about, you know, if we can work with MACA and other organisations out there, actually just that reaching out to people. It is difficult, as I say, because people don't tend to come forward. It's not seen as the normal thing to do, the usual thing to do. So what we're hoping is that Health Watch will be able to give us the information or some of that information so that we can start reaching out to people.
Councillor Wilding.
If I can just come back on 2 points, the 20 days, do people get a holding email or letter just to tell them we're looking into it, but within a quicker time span? And one other comment, really, for the committee, Health Watch was mentioned. I think it would be helpful if Health Watch could start to put a representative back on this committee as they have done in the past. And you know, if Michael could ask them. Sorry, because that's not really what we're here for, but Sandy?
In terms of the 20 days, they would be, the complaint is acknowledged at the beginning, within 3 days, then sent a letter, then the complainant is told when the date will be that it should be due. That would be the 20 days date. If then we're not going to make that, they'll get holding letters through the process, telling them, sorry, it's still not there. But usually it's only one holding letter because they're not delayed by more than that.
No, but the point was they will hear back within 3 days, not the 20, you know, not
Yes,
wait 20. No, that's fine. Thank you.
It's acknowledged that they got it, because that's a worry for complainants, and they usually send a letter and an email. So yes, that has to be acknowledged in 3 days.
Thank you. Thank you.
Thank you. I just had a question, and it was regarding when you pay financial redress to complainants when they're upheld on the basis of a complaint about a private care provider. Who foots that bill for the financial redress, and do we have means of recovering it if it is the council? Thank you.
So it tends to come from the council if we're doing that. We do work with the providers, but because we have the statutory responsibility of placing the person in the care home, it does tend to be the council that makes that payment.
And is it, sorry, I know, is there any way of recovering it from the private
We have
providers?
an interesting complaint where it's in here with the lady's possessions after she died were just destroyed, given away. I don't know what happened to them. And in that one, there was in the contract the time that they would pay to clear the day. You know, it didn't sort of say, okay, it ends on the day the person dies. They gave them days to clear. And also, there was something in that contract to say that if there is any financial whatever costs because of the care provider's fault, we can claim it back. Whether or not it was paid, I don't know if you know, it wasn't paid, but it was in the contract. The problem is that under law, it's always you take your dry cleaning to the shop or the people who dry clean it, who's the one responsible? We are, Medway Council are, because we've commissioned the service. So they will always, the Ombudsman will always come to Medway Council for that payment back. Just to also say, I've done training with Jack in our commissioning team, and we did training for, it was 25 service providers, which they found very useful, and these sort of issues were explored with them, that there are consequences and there can be financial costs to when we make mistakes. I'm hoping to continue those on an annual or twice annual way, so that we are training up the service providers to take complaints very seriously now and to take responsibility for them. Whether we can get the money back, I can't answer.
Thank you for trying to answer.
Oh, we're trying, yes.
Any more questions, members? In that case, I thank you, Sandy and Michelle, for coming along this evening, and move to Vice Chair.
I move that we note the report.
Seconded.
Sorry.
I second that.
Thank you very much.
It's agreed.
Agreed. So next is welcome to our Deputy Leader, who's submitted a report in the papers which we will assume is read, take as read. Did you have anything to introduce, or are you happy to start with questions?
No, I'm very happy to be here. I'm very happy to start with questions, and I hope that everyone's read the local account, because I think it's a really great encapsulation of all of the things that we do in adult social care.
We're happy to have you. Who would like to start questions, members? Anyone? Councillor Prenter?
Thank you. I read the report and I'm very pleased to see that we've recruited 7 new social workers. Is that going to be continuing, or is that the limit of 7, or are we going to fill more and more and more social workers as we go through? And are we going to be replacing agency staff with continually as we go forward?
Thank you very much for your question, Mark, and it's an important one. First of all, obviously, we're delighted to have the 7 newly qualified social workers here. They started this month, and I'll be meeting them as a group at the beginning of November to make sure that they feel welcome and to hear what they've got to say. And absolutely, it's our intention to recruit as many newly qualified social workers as we can. But as people around the table, I'm sure will know, we've got to be careful, because for every newly qualified social worker that we recruit, then that person needs supervision. And just at the moment, with more agency staff than we would like to have, many more, I'm afraid, we have to be careful that we maintain the stability of management. But lots of things are happening. We've had attendance. James was at an event at Mid-Kent College just this week, talking to the health and social care students. We're in close touch with the universities to encourage people as much as possible. And this morning, I met the whole division. So it was really lovely, actually, to see everybody assembled over at Lordswood Leisure Centre for a half-day away day, which Jackie is trying to do every 6 months and more frequently than that if we can manage it. And one of the things I said there was, stick with us, please. We want Medway to be an employer of choice. There are challenges now. And I think, you will know, you'll feel it. While we're so challenged with the budget, it's an unwelcome narrative to staff. It can make people feel very uneasy. It can make them feel demoralised. It can make them feel unstable. And so I felt that it was important to go along and play my part in saying that we will get on top of the budget, that we are doing things with the MedPay scheme to try to bring up the local wages that we pay, because we know that our competitors, including Kent County Council, are paying more, and that's drawing away. And I think over time, if we can demonstrate that we value people, we support them, we want them to have training and development and decent wages, then that's the way to get that agency staff down. But it is a problem, and the agencies are taking advantage of it. They are often saying now, if we ask for one social worker, they will say, no, you've got to have a project team. So there's money being made by this in, I think, fairly unscrupulous ways. But for all that, we value our agency staff because for now, they're part of our workforce. And we've got to make sure that they get the same level of information as other people and actually the same level of support. So it's a matter of being sensitive and careful, but determined that we want to get on top of that problem and sending out a positive message that social care is a good career. It's as economically important as any other kind of career. It generates jobs. It can be a harbinger of innovation. There are things that can happen that will, really interesting developments. And it's about all of us, actually, collectively, putting out that positive message about Medway. But it's a really important question that you've asked.
Thank you. Councillor Clark.
Thank you, Chair. Just a quick question on the figures. Page 53 gives projection of adult over 65 increasing to 48,400. On page 55, though, we've got the ONS population growth, which has got 51,200. Obviously, in the same document, we've got conflicting things. And the concern is, what are we budgeting on? And what are we planning for?
Thank you. Jackie.
Okay, yeah, thank you. So we have a problem at the moment where the 2 reports are for different years. So the local account is for 21-22 and the holding to account is for 22-23. So we're bringing that back in line next year when you'll see the figures fall in line with each other. So we'll come back to what's in the JSNA is also in the local account. It's because both the reports are different. From a budgeting point of view, it doesn't go on the demographic, that 50,000 figure. It's worked out on how many people we support now and then what we are forecasting as being a percentage increase in the coming years. So it isn't against that 50,000. So when I said earlier on, we support 2,500 people, or sort of nearly 3,000 people for care and support, and then another 2,000 from a social work perspective. When they're looking at demographic growth, they look at that sort of 5,000 figure and then work out what the increase in the budget will be for that.
Sorry, so just to be clear, so we're looking and planning on the ONS figures then, as opposed to this lower figure in this report?
So it's not on the ONS figures, it's that we plan the budget on. The budget is planned on the number of the people that we actually support. So when we're looking at trajectories, what's coming through in the coming years, then we have to consider how do we increase the budget. But we don't do it on the ONS figures because we'll never support that many people in adult social care. That's the population, but we'll only ever support a small percentage of them.
Understand, it's just that obviously anyone cold reading this would see a difference in figures on the following page and perhaps would send out the wrong message that, you know, we're not really on top of this.
And as I say, it's always been the same. We've been exactly the same position in the previous administration where we were never aligned. It was always the local account for the year before and the holding to account for the current year. But we've been working with democratic services to look at how can we align that so that when we present next year, we are doing the holding to account and the local account for the same year.
Councillor Hamandashi.
Donna, thank you for the report. It's very uplifting. I just want to speak on behalf of the voluntary sectors who do a tremendous job in, propping up their health service and coming in to do a lot of preventative work, one of which is hypertension. And we all know 1 in 3 is succumbing to hypertension, high blood pressure, and that can lead on to other complicated health conditions such as heart attacks and strokes and whatnot. And I'm pleased that the Hypertension Heroes Programme are shortlisted for award, and I really hope they do get it. But assuming they do get the award, what can we do that will boost their morale, most definitely, but what can we do to sustain those services by giving them more resources, because hypertension is on the rise?
Thank you for your question, Douglas, and I'm really pleased that you've acknowledged that nomination. And one thing that I might say, referring to some questions about the participation of ethnic minorities from both sides of the room tonight, is that actually within the Hypertension Heroes programme we've had fantastic pickup from ethnic minority groups who have worked within places of worship, within their communities, to really get people to engage with that programme and come forward, because we know that there is more prevalence of hypertension in particular ethnic minority communities, and that really has been, through the Diversity and Inclusion Forum, a fantastic pickup. And I was very pleased to join Nina Gurung in a sort of celebration of diversity here in the Chamber, where one of the things that people talked about was how much they'd enjoyed participating in the Hypertension Heroes. So going forward, absolutely, we need to keep it going. There's no question about that. We need to train more people. We need to work with the voluntary sector to make sure that that resource is actually very embedded in our communities. It's one of the best ways to tackle health inequality. So I think in terms of the kind of public health strategy for doing that, Douglas, we need to do more work, very granular work, actually within the communities, and to keep it going. It isn't our intention to stop just because the programme ends. It's a matter of embedding that and running it through. And there have been lots of, and also working with the NHS, that we've had the bus here quite a few times. I've met with the NHS and said that they could do better, rather than just telling everyone, oh, there's an app, you can look on it and find out when the bus is coming. They could do better in advertising it, because I've seen the bus outside the Pentagon Centre a few times where people can go in and have a full health check, and there's nobody there because people didn't know it was coming. So I think we need to rely on our partners as well to work together to make sure we have as wide as possible access to that. But, I do congratulate the Hypertension Heroes. They've worked with tremendous enthusiasm. They deserve to be nominated for an award, and I think the support that they've had from James's team has made a real difference.
Thank you.
Councillor Wilding. Councillor Wilding, can you put your mic on, please? Thank you.
Thank you. as I say, I always sound better without it, but no, thank you. On the agency staff, which do tend to come and go, our people that rely on them would prefer consistency, which would be ideal for all of us. We all understand that. What work goes on to keep the same agency staff for a certain number of weeks, months? How long do they normally stay for before they move on?
I'll speak first and then I'll ask Jackie to give you the detail in that. And yes, of course, you're absolutely right. Everybody would prefer consistency. In 2019, there was a reorganisation where a huge amount of staff were taken out. And in the last 5 years, £15 million has been taken out of the adult social care budget. So it's not very surprising that we're in this position, and it's not a good position to be in. There's nothing worse for a family than talking to lots of different people. So we are hoping over time, and Jackie and the team are working on this now, to return to that allocated model so that people will have a much greater chance of seeing and being listened to by the same person. But that's going to take time to bed in. As I said at the beginning in answer to Mark Prenter's question, nobody wants to have so many agency staff. It's expensive. It's hard to get continuity, it's hard to get consistency, but it's the position that we're in. What I hope, and this has happened, in fact, I went out myself 2 weeks ago with a social worker who had come here as an agency member of staff, has now joined our establishment and actually is being trained to be a practice educator. So it isn't as if it doesn't happen that people convert to becoming consolidated members of staff. It's about us showing that that's a good place for them to be and that the benefits of being a consolidated member of staff, such as pensions and other staff benefits, outweigh the flexibility that people enjoy from being an agency staff. Jackie, if you want to just say about the amount of times, in fact, it does vary a great deal, and we have unfortunately got people who've been agency members of staff for 6 or 7 years, which obviously isn't acceptable.
Thank you. I mean, Teresa's covered most of it. I think just to give you some examples of things that take place. So every quarter there is what we call a temp to permanent event. So that's Leanne that actually meets with the temporary locum staff, talks to them about the benefits of becoming a permanent member of staff in adult social care. And we've seen some conversions. Councillor Murray's just mentioned one, but there's a couple of other people that are always talking to us at the moment and saying, actually, we want to become a permanent member of staff. What can we do to move that forward? We're working with HR, so obviously we've seen there were some successes in children's services previously, so we're learning from them. Obviously, with children's getting a good Ofsted result, it means that we can get some additional resource from HR that we've not been able to have before, so that will support us too. And it's also things like just that recognition and meeting them. You know, if we've got like a lunchtime learning session that I just go along to and sit down next to them and have a chat, you start to really understand what's happening and going on, and you can just sort of nudge people and say, you know, come on, you want to join. So lots of different things that we're doing. With regard to consistency, yes, it is definitely the case that we've got some people that have been here a very long time. But what we always try and do is make sure that we're not got that sort of throughput, so that when we recruit an agency member of staff, if we find that actually they're not working to the standard that we would want them to be, we ask them to leave very quickly so that we're not getting a big churn. We're quite successful with that, I think, but it's just the fact that we've got too many. That's the issue.
May I? I think this is more for Jackie, but the question is, how many permanent staff do we lose compared to the agency staff, as in, are more of our permanent staff leaving and becoming agency, or just leaving working somewhere else to the agency that joined Medway?
So I can't give you the exact numbers now. I have got them, but I can't give you them now. We've seen a slight increase over the last. So if we ignore September, because there was no leavers in September, but prior to that we did see people leaving. Now some of that is due to actually the ability to go to different local authorities, get different experience, you know, and really develop themselves. There is the odd one or two that it is about money. There are people that have trained to become AMPs or trained to become best interest assessors and want to progress in different areas. So the principal social worker actually meets those people. When we hear the rumour that people are going, she meets them and talks to them about, you know, what's the reason behind it and can we do anything to encourage you. But I can come back to you with the numbers.
Thank you. There are a few other questions, if you don't.
Actually, if you don't mind, could we all have those numbers? Yes. Yeah, come back to everyone. Thank you.
Yes. You talk in these papers about working with the ICB and how you wish to work. 4.7, most recently attended a workshop to refresh and reaffirm our common commitment to the health outcomes identified by the ICB, which is fine, except for the ICB and the CCG that preceded them certainly didn't do Medway any favours, moving vascular out of the area, moving the stroke, which you're well aware of stroke, and I think we're in agreement that stroke, HASU should have come to Medway. I could go on, acute mental health beds, etc., etc. How do you find it to work with a group that has consistently not done the right thing by Medway?
Yeah, I think that's a really good question, David. And over the years, you and I have shared the travails of that. First of all, about the workshop. That workshop was about health and well-being outcomes, you know, how we want people to be well, how we want to have preventative work. It was a general professional consensus about what we want to achieve. It wasn't actually about the services and systems. But yes, you're absolutely right. We've got to be at the table, always fighting our corner. I've been clear from the start that whatever the outcomes that are agreed, we've got, in most cases, sadly, further to travel in Medway than other parts of Kent. So when it comes to the allocation of resources, to get to the same outcome, we need more resource. And I think, you know, people will tire of hearing me say that, but I do say it at every opportunity, and I intend to say it this Friday again, when we have a symposium for the whole local health economy in Medway. And it's clear to me the ICB are still in development. They've got their own challenges. They're in the process of making the 30% cut that they've been asked to make by the government to their own people. So there's a lot of churn and a lot of changes there. And as far as our local services are concerned, I haven't got the feeling that they want to prioritise Medway in the same way that I do or the same way that you do. So it's up to us collectively to continue to make those arguments and to work through our primary care networks and our healthcare partnerships, which are place-based, to have that joined-up voice and make it loud enough in the ICB so we don't lose things. I'm disappointed. I'm really pleased to see the work that Scrutiny has done. An example of that is the movement of the TIA service to Maidstone. I was very unhappy about that. I've had direct experience of attending the clinic with a family member at Maidstone and was able to speak to the consultant who told me he is doing twice the volume of work for no extra resource. So not only are people in Medway having to travel over to Maidstone as things stand at the moment for the TIA clinic, they're in a position where when they get there, they have to wait a long time to see a very nice, very hard-working, but extremely pressured consultant. That's not the picture that was given to me when that change was made, so I have challenged it. Similarly, I've challenged, and I'm glad that all of you around the table here challenged, the idea that we're going to move to a single provider for community services. That is a red flag to me. It could easily mean that we start to lose things from Medway. We've got to do everything that we can to prevent it happening. And the way to do that is to demonstrate need. Luckily, as you will know, we've got a fantastic grip on data here and have always had through the whole of the stroke process, through the acute mental health beds. But I still believe that grip on data that we've got here is a way for us to have actual evidence about retaining services in Medway, and I'll continue to use that.
If I may, you meant I will come backwards and forwards, or do you want me to ask all my questions?
I've got 3 waiting. How many have you got?
2 or 3?
Okay, go ahead.
I
and
can
then
come back later if you want.
No, it's all right. You're
Right, a comment on the TIA. As the CCAM report on the last agenda, it takes 90 minutes to get an ambulance to someone that calls out an ambulance for a TIA, but 9 times out of 10 they don't call them out for a TIA, they call them out because they think it's a stroke or a heart attack. So again, I will be asking this committee to be looking at CCAM on that issue. And again, the TIA was put in place at Medway, or kept in place at Medway, from the stroke review. You might remember as part of the mitigation. So in your conversations, if you can remind them with that. That was more of a comment and a discussion. On page, sorry, it's not very clear, 56, we talk about the locality teams and they're aligned with our GP community health service. Well, with our falling numbers of GPs, I do think you do need to push to the ICB that, as the task group should have, met with GPs and to make the case and the recommendation that we need more GPs within Medway, being one of the areas with the lowest number of GPs, which, as you know, you were very happy with your report and your recommendations, and you took it away from scrutiny and you took the decision-making point of view to Cabinet. Now, that to me is...
Is there a question, Councillor Wilding?
The question is, shouldn't that have been left up to scrutiny to see out the task group, not go to the Cabinet decision on a minority report?
Well, you and I disagreed on that at the time, and
Yes.
I disagree with you today. It was a full report and a well-reputed report that included contributions from many people right across the health community. The fact that we weren't able to see lots of GPs, I don't think diminished the recommendations. It's being worked on now. We'll have an update in January as to where we've got to. We have had some new GPs start in Medway. Absolutely, we need more. We need more practices to become training practices, as recommended in the report. And we need the ICB and the healthcare partnerships to support that happening, as well as all of our friends in the medical schools. So I'm optimistic that, rather like getting social workers here, we can get GPs to work here if we demonstrate that we value them, that we're prepared to help and support them, and that Medway is a place where they have got plenty of opportunity for training, development, a range of pathology, help with housing, help with working with a whole range of practitioners. And I was really pleased, actually, to find that BBC South East covered that, and you saw yourself the coverage that the maritime practice got on television as a really good practice. And since then, they've had actually lots of requests from other GP practices in Medway and actually from outside of the area to come and learn from them about how successful they've been with the use of technology. So yes, there is a long way to go. I think taking it to Cabinet meant that it could go more widely, and actually those actions could start being worked on. And Scrutiny will get the update report, as we always have done, with task groups, and I hope that when you see it, you'll be pleased with the results.
And my final question...
Make it quick then, please, Councillor Wilding.
Well, it is again on GPs. The numbers are still falling. You took it upon yourself to take it to Cabinet. If I take you back to June 2022, when I had to go to full council, and I can quote, Councillor Murray talks long and hard about the GP task group, which I'm pleased that it's promoted. I would just like to be a little bit more pleased if she will please attend more than half the meetings, if that's possible. You've got to remember this.
Are we keeping the
date.
question, Councillor Wiley, to the actual report here and what's been happening,
Thank
which is
you.
the update since
Thank
May?
you.
Is that the question relating to that?
Yes, I know we all have busy lives, but you keep talking about particular meeting, you should be able to attend them. Do you think it's right that the member that attended the least number of the meetings decides to take the decision and the recommendations away from the members of the task group and the members of the task group that voted to continue the task
Councillor
group?
Wiley, that
to
question's
Cabinet?
not connected to the report that we've been given that we're asking the Deputy Leader about. Are you willing...
I'm sorry,
I'm-
GPs are mentioned.
I'm perfectly happy to answer it again. I missed 2 meetings for good reasons, and perhaps unlike you, David, I trusted my colleagues who were there to carry on in my place, and I read the reports afterwards, I picked up with officers, so I was very happy. So the answer to your question is, yes, I do think it was absolutely appropriate for me, as informed as anybody, as interested as anybody, and as someone who pursued getting that task group at all, to take it to Cabinet in the way that I did, and I stand by my decision. I'm very pleased that we were able to, and I look forward to the good things that are going to come from it.
3 meetings,
Thank you.
but thank
Councillor
you.
Campbell.
Sorry, I didn't see that on the response. Thank you.
Sorry.
Thank you. Thank you for this report, Teresa. It's been a pleasure to read, and I think we all welcome fresh eyes and renewed energy on this topic. And I think you have your task cut out for you, given what we're dealing with. 91% funding cut. I know that figure is now out in the public domain. So, and it's not just a figure. Frontline, vulnerable people, that's who are going to be suffering the brunt of the brutal cuts that the government has inflicted on local authorities. So in that context, it's really positive to read how much energy and a focus you're putting on this. I have a question around social prescribing. I know social prescribing is a big part of the care model at the moment that we provide to people in the community. And I have experience working in that sector, in the voluntary sector. In your report, you've made reference to the voluntary sector, the critical role that they play in giving that joined up care to adults, vulnerable adults. My point is, though, that social prescribing cannot and must not replace appropriate medical intervention, proper, timely assessment, and the support that people need. I know it's a balance. It's a balance between personalization, which I know is one of your priorities here, meeting people where they are at and finding sort of wholesome solutions, not entirely just clinicalizing care. But it's also about not denying them the care, medical care that they need, even though it might be low-level interventions. So this is, I'm speaking from personal experience here. It can feel sometimes, if you're not critically ill, that you're being fobbed off. So my question is, I'd like your assurance, please, that when you're considering the care model at the moment, that we are going to prioritize medical intervention as and when needed and not rely excessively on the voluntary sector and social prescribing. And I've got a second question. I'll ask that quickly, then I'll shut up, I promise. The second part I wanted to say, how important is digital inclusion for you, especially in the context of innovation and sort of, moving more towards technological intervention? A lot of people still will struggle with doing everything online or on the smartphone. So I just, again, want your assurance that digital inclusion is at the heart of everything you will be doing. Thank you.
Yeah, thank you for both of those important questions. Look, absolutely, Smither, I'm with you. If social prescribing... If social prescribing replaced medical interventions, then it isn't really social prescribing because there's no chance of it working just on its own. And I think more commonly, it works alongside medical interventions. And that's the way that practitioners should see it. And I don't want people to feel that they're fobbed off, because opening up opportunities to do things that make people feel better is really important. But we can over-rely on the voluntary sector, both on their capacity to deliver social prescribing and indeed on the efficacy of social prescribing itself. Very little, actually, is known about how effective it is. You know, that's work that's still to be done. And I think unless and until that's done, and we start to see the way that it, you know, prevents people from being completely medicalised, prevents people from returning to a sort of medical intervention after they've recovered, it's at that point that we can assess just how much we need to, you know, build it up and how much we need to use it and look at the different ways that it can be used most effectively. So you're absolutely right. And I don't think, you know, that there's danger in substituting one for the other. They should complement each other, really. And I haven't met any practitioners who think that social prescribing is a substitute for medical interventions. You know, it is seen as complementary, and it is seen as a way to keep people well for longer, and that is really important. And I've just missed in my mind the second part of your question there. Yeah, that's very important. When I've been speaking to community groups, and particularly where there are older people, I've asked them very directly about this, because it's one of these things that we talk about very freely and very easily, and actually the reality of it is something quite different to lots of people. It's not the case that if you've got a smartphone, it means that you can do everything. There are different grades of smartphones. Some people don't have access to the internet. It's getting increasingly expensive, actually, and we're seeing some households coming away from having a home broadband link because of that. So I'm very mindful of that. What I have been impressed by is particularly with older people, there's no reluctance on their part. What they would like is more training and support. So I've spoken to our adult education teams about this. I've spoken to the university about it, and I'm hoping that we can get to a position where we offer not lessons, because people have told me, well, I went along to a lesson to learn how to use a computer, and what I found was the teacher was too busy, everybody was at different stages, it was hard for me to get to grips with what I want. What people, I think, would like is a drop-in workshop for somebody to work with them for a period of time. And a couple of organisations, the Net is one of them, Who Cares is another, are prepared to, you know, sort of experiment a bit with this and work with adult education to bring people over and see if we can get people going. And it's not just for, you know, finding out where services are or paying bills. It's also about building up people's resilience to use assistive technology. So actually to use medical technology where they can monitor their own health, use a blood pressure monitor, you know, monitor their SATs, report that in to somebody to tell them on the computer. You know, all of these are ways, actually, in some parts of the country where there's really been a strong advance towards using assistive technology to promote independence, to do health monitoring with the involvement of the person who's actually being cared for. But I think it is about tooling people up and making them feel confident, and I don't dissent from that in any way at all. And it may even be, over time, that we need to think about the way that our hubs, the way our libraries, the way the front-facing part of the council provides opportunities for people actually to come in and get some help with those kinds of things, you know, at every encounter. So, you know, you're right on the button there, if that's the right word. It can be talked about a lot, but the reality of people's experience is that they need more help and support to use it. And I think we can find some interesting ways. And I've had, I went to speak myself to a group of ICT students at Mid-Kent College who were doing level 3 courses about their willingness to volunteer and come out and do that, and they were quite pleased to do it, especially if they were doing something like the Duke of Edinburgh's and so on. So I think we've missed a lot of opportunities, and I think we can take advantage of them.
Thank you, Chair. Teresa, thank you for the report. The digital inclusion is great, and I'm glad that we're thinking about that. Actually, unofficially, and just on a one-to-one basis, one of the libraries in my ward is an absolute exemplar in that situation. People come in and say, I can't do this, and I've witnessed this myself, where library staff have gone and said, what can't you do? Talk to them on their own device, not a device provided by somebody else, but to use their own device. And Greenwich, about 7 years ago, ran a very similar thing whereby one-to-one support was given to people to use their own device to do the things they wanted to do, not a class, not things we wanted them to do, things they wanted to do, things they needed to do. And I think this whole openness and transparency around what we're trying to achieve is good. My question is around section 4.6 in your report, in which, as I read it, it is quite different, I think, in turning the relationship with the ICP from a sort of scrutiny one to a cooperative one. I know it's early days and you've only had some meetings with them. Do you have a feeling for when we might notice the shift from the other side, from our partners in this? Thank you.
I think, respectfally, Hazel, you're talking about the section that talks about the Health and Wellbeing Board, which I've tried to change from, it had kind of developed into a sort of another level of scrutiny, and that is important. But what I've said from the outset is I've tried to have themed meetings, and one of the meetings we're going to look at actually is technology. We're going to look at that in November, and I've got a presentation coming along for that and some case studies that we're going to consider. And what I've said is I want the Health and Wellbeing Board to be a board where every single member of it thinks about what can they contribute to whatever it is we're saying that we want to do, rather than sitting there, because scrutiny has got that role, you can hold people to account. We don't need to do that on the Health and Wellbeing Board so much. It's about mandating all of the partners around the table to think about what can they do to contribute to whatever it is that we're trying to do. So it just seems to be a new and perhaps refreshed way of doing it that actually so far seems to be working. We've had 2 meetings and they've both been very positive. And we've refreshed the health and wellbeing strategy. Got some really good work done there at the beginning of our administration. And on that basis, we're using the things that have come out of the strategy to have, as I say, those themed meetings where we think about the contribution that all of those partners can make. And I think for the Health and Wellbeing Board, that's a better way of working. We also had a development session, actually, had someone down from the LGA to sort of point us in the right direction and get the new members in a situation where they felt, confident about being able to say whether they thought that would be a good way to go. And so far, 2 meetings in, third one in November, it's working. So thank you for asking about it.
Sorry, and apologies for calling it the wrong thing.
No problem.
Councillor Crozer. Oh, Councillor Crozer, could you switch your mic on? Thank you.
I do beg your pardon. Thank you, Teresa, for the report. Can I pick up on your comment about some people don't access the internet? I think it's many people that can't access the internet, and also many people of my age and older, and certainly some younger. And I think it makes people switch off from everything, not just social care. And I wonder whether we have any figures on just the number of people that don't have access to the internet and what we're doing about that. That's my first question. My second question is about page 53. You've got you highlight under key facts, 1,404 adults are known carers. I'm sure that's not the total number of carers that are in Medway. Why are we highlighting the 404 known carers, and why is it on there? Thank you.
You can come in. Look, George, you can say most people, you can say some people. What's clear is that not everybody at the same time has got the same level of access, and we have to accommodate that variation as best we can and acknowledge that when we're talking about a digital service, there are people that we're going to miss out, and we've got to do our best to find them. And, that the work of the voluntary sector is very helpful in that, actually. The groups that I've seen are very prepared to to talk about it. And to be honest about it, I was over in Who, and we had a really good conversation, particularly with two people who had brought the people that they were caring for with them, and spoke about actually the benefits and disbenefits. You know, one of the things, if you're caring for somebody and you're at home a lot, being connected to the internet is really welcome. And you know, people were telling me it's really nice because we can have a Zoom call with the family if they can't come visit us and those kind of things. But the other side of it is that, you know, when you're trying sometimes to do something like fill out a form and you're not very good at the sort of digital manipulation, it can be very frustrating and make you feel very excluded. So we've got to play both sides of that. Oh, look, we don't, of course, know the real number of carers, because the people that present to ourselves as carers who may be in receipt of a carer's allowance, who have asked the council for help, are the people that we can work with. But I'm very mindful that there are people lovingly and willingly getting on with caring for a family member who we never see. And it's about being open and as visible as we can to the support that's on offer. Making sure that if people have, you know, perhaps come out of employment into a caring role, they're claiming the carer's allowance. There's the terrible and I think vindictive situation, whereas if you're claiming universal credit and you get carer's allowance, that gets deducted from your universal credit, which impoverishes a great deal of people. Just sharing with you, on Saturday, actually, I was canvassing in my own ward, and I met a guy whose wife had got early onset dementia, age 62. They were a second time around couple. They still had a mortgage. Everything had collapsed around this terrible bad luck of the condition. He had given up work. He was a willing and, you know, loving full-time carer, but the mortgage rates had absolutely clobbered them. And he asked me, you know, what can be done about the fact that I get universal credit now and the carer's allowance is deducted from the payment that I get. That is absolutely unacceptable, and there's, you know, lobbying at government level that we still need to do about the situation that people find themselves in. He hadn't got interventions from social care. I asked him if he wanted an assessment. He said yes, he did. He had had adaptations from the council and was very grateful for them. And I think it's about making ourselves, all of us round the table and across the council, as well as staff, open to hearing those things from people, that people can come forward. It isn't necessarily that people will always want an intervention, but the ability to talk about it and think about the support that's on offer is really important. So the more carers we can identify, the better. Not to pigeonhole them, not to designate them, not to, you know, impose the language of social care on their lives when they're just doing what they're doing, but make them feel that there is a benign and helpful force in the council that wants things to be as good as they can for them.
So, quickly follow up. Are you asking them people to come forward that are carers but are not registered or whatever that?
Yeah, I mean, absolutely. That's the point of having the local account, really. So that's in the public domain. We can say what we're doing, and we can make ourselves open. You know, there's information in here about what should you do if you feel like you need support. You know, very often people don't want to be labelled as a carer, but they are one. So I want them to avail themselves of such support as there is and make sure that they're getting everything that they can. And that's something, you know, we've got to speak the language of social care across the council, so that at every encounter that somebody has, if there's a need, staff and all of us are open to making sure that people get that support that's on offer.
So quickly then, do we know what the number of people that are without internet? We've got a handle on that number, and what are we doing about that?
Yeah, thank you, Councillor Croser. So I couldn't say today how many, but there's a digital data and technology strategy that's been developed by the Chief Information Officer in the Council, and that will be considered as part of that, because we do know that there are people out there that are not able to access, or actually signal is poor. You know, there's real challenges. I mean, having been a former visiting officer, you go out into the peninsula and you struggle, and then you go to Snodland and you struggle. So that strategy is looking at that and how do we reach out to people and support them with the ability to get that technology, but considering what Councillor Murray said about costs and so on and so forth. So I think that's something that will be coming over the next few months, but it isn't available readily today. If I can just really touch on the carers quickly, I mean, Councillor Murray's, you know, she's commented on that, but just so that you're aware, when the social worker goes out to do a Care Act assessment, a care needs assessment, if there is an informal, so it's an unpaid carer that is supporting them, we ask them, do you want to participate in a carers assessment? Some people say yes, that's where that 1,404 people come from. Some people say no, exactly for that reason, that they don't want to be labelled as a carer. But what we do is we refer them to Carers First. So we commission Carers First in Medway to support people who are carers. And so it may not be that they get a care assessment through social care, but they get support and intervention from Carers First.
Okay, so we'll go to Councillor Cook, then Councillor Jackson, and then Councillor Hamadad.
Thank you. I wanted to thank you very much for this report. I wanted to say how much humanity and compassion I felt we saw all the way through from the people of Medway, and the real pride that we have for our communities. You've mentioned the net, Walt has mentioned, both in Weedswood, you know, people working incredibly hard for the sake of our communities. I wanted to also say thank you for the real focus on women's health, and to draw attention particularly to 3.10 and 5.2, both which talk about work around being a menopause-friendly workplace, menopause-accredited employer. And I think that's, you know, I'd really like to congratulate on that focus. And just to ask a little bit more around why that has such prominence, what do we hope the impact of that will be, not only for the council as an employer, but for communities around Medway, and whether that would have any economic impact at all. Thank you.
I was hoping that someone would ask a question about that work, Esther, because it's really important. So the People Directorate has got the accreditation, and we're working towards getting that accreditation right across the council. And what it means, it puts the onus on the employer to make reasonable adjustments if we need to do that, to allow people the space and time to talk about the way the menopause is affecting them. And here at the council, actually, there are menopause cafes on a monthly basis where people can get together and talk about it. And the reason it's got so much prominence is because it's had no prominence in the past. There have been some sort of celebrity interventions. You might know that Davina McCall is a big advocate for making sure that people understand about the menopause. And I think it's a real balance between saying that it's a perfectly natural process. It's a process that often in itself happens only to women, and we deserve the recognition for that. The change that it can make to the body and to the way that you're dealing things is huge and affects people from the age of 35, actually, to the age of 75. There's a huge spectrum. And it's really important that we make the space and time to allow people to talk about it, and that they get services. We had a fantastic event, actually, just last week, around World Menopause Day with our health partners. And at that event was a specialist doctor. Now, I think there were about 200 women there, and hardly any of them had had the opportunity to see a menopause specialist. In fact, what they'd normally done is gone into hand-to-hand combat with their GP, trying to get some actual specialist help, having to fight for a blood test that tells them what stage they're at, having to source information from a huge sort of range of disparate sources about the different ways that particular condition can affect you. So it was really refreshing to see that there is specialist help out there, that there is a determination in the health community to make sure that specialist help is more wide. And we're hoping to move to a situation where we have women's health hubs, because, you know, respectfully to all the lovely gentlemen in the room, it is something that we have to focus on particularly, as women and understand as women and get men to understand as well. So that prominence, that ability to talk about something that is perfectly natural but tricky to handle, I think is really important. So the menopause-friendly workplace is part of that, but actually putting in place those specialist services and specialist help to enable people to cope with that period in their lives, I think is something that we need to do much more of. And after that event, I came back feeling very optimistic that there was a determination in the health community to make that happen.
Councillor Jackson. Oh, I beg your pardon, Councillor Cook, did you want to...
Just very briefly, just the last bit of the question then, is that something that's going to have economic benefit for Medway?
Yes, absolutely, because there are people, and we heard from them last week, who give up work because of the menopause, because they don't feel that they've been listened to, they don't feel that those adjustments are going to be made, they've often been actually discriminated against. So yes, it definitely will, because the wisdom and experience of women who are going through the menopause at both sides is incredibly important, not just in their profession, but to the workplace as a whole. So I think that kind of hand of solidarity and support from everybody, that this is something that can be overcome, this is something that there is help for, that we value you as a person. Just because you forget things or find that you've got to have all the windows open every 5 minutes, or struggle with, unplanned bleeding, whatever it turns out to be, we need to show that we've got that understanding. And actually at that event, there were a fantastic pair of women who call themselves the Swale Sisters. They're actually women who work at Swale Borough Council and realised that there was a need, and they've set themselves up not as a charity but just as an organisation, supplying special pants, advice, pads, different things across Swale Council and across the whole community, delivering packages of help to people who are struggling. And I just thought that was an incredibly brave thing to do. It was great to see them there. And I think just as we've had our initiatives on period poverty, we need to think, move that up a gear now and think about a different time in a woman's life where she might need some extra support. So I think for the first time in my life, it's happening. I don't think my mum would have felt, and I've asked her about this, she's still going along, age 94, I don't think she would have felt comfortable about talking about the challenges that she faced. I don't actually think, rest him and bless him, my dad would have listened or cared very much about it, because I've got a memory of those days. I hope we're different now, different and better.
Thank you, Councillor Jackson.
Hello, sorry, I don't want to go back, but it's just about the digital bit of this. I work with GP surgeries in London, and today I was in East Ham doing face-to-face digital training with members of the public. And you're so right, we've done this for a year now, it has to be one-to-one. But what that brings is not only smiles to people's faces when they realise how easy it is, but it builds the GP back up into a community. So the calls to the GPs have gone down by 25%. The GP surgeries can then put events on because they're not answering the phones. We train volunteers up that are patients of the practice to learn how to use the apps and how to use the websites. So it's the patients that are now training other patients, which is really empowering, because I know you said about students, but if you get people over 65 that are now training other patients up over 65, it's amazing just to watch and see how empowering that is. They also get involved with the GP surgery becomes back the hub where they put on their social media, so that the volunteers look after the social media and the events that go on in the GP surgery. So the GP surgery becomes back the hub. So I just wondered if you had thought about the, because I've lived in Medway for years and I've never been asked by my GP surgery whether I want to join the PPG or have a volunteer, and then people get to have a say in their healthcare and what happens in their GP surgery. So that way you're not using digital to isolate people, you're using digital to bring people together back into the surgeries again.
That's a really good point that you make. I mean, in the GP task group, we heard from some PPGs. Not every GP has an active one, and actually it's a mandatory part of what GPs should be doing. So I think you're absolutely right. That's made me think we should have a drive to get people to join. And certainly, I knew a little bit about that work that you were doing, but using your expertise and your contacts to see how that's actually worked and trying to get some of our primary care networks to perhaps join in with that, even if it's through a Zoom call or whatever, I think that would be a really good idea. So if I can draw on you as a resource, that would be great, actually.
Totally. I mean, it's so lovely going into GP surgeries and like they've got gardening groups. They've actually got plots of land in the GP surgery where the volunteers come and they have a coffee morning and look after the plants and everything. And it's just amazing. It's become, I feel like the GP surgery has to come back to being the hub. And digital can help that, not go against it.
No, that's a really great idea. Thank you.
Thank you. Now I've got Councillor Brake and Councillor Anang, and then I think I'm going to call another one from Hamadashi, okay, and that's it.
Thank you very much. Thank you for the report, Teresa. I'm going to go back onto the subject of GPs, in as much as that both at Kent and Medway alone on health and well-being, over a significant period of time, many questions were asked concerning the strategy that was being put together to ensure that both Kent and, in particular, for our case, Medway, were being looked after with regard to the shortfall of GPs. At the end of the Conservative administration, this in fact was an item that was still outstanding, and I'd be pleased to understand, could you tell us where we are today? What is the strategy that's been agreed with regard to the shortfall of GPs across Medway? Thank you.
Yeah, thank you. Absolutely, there's recognition at the ICB that there's more work to do. You'll know that we saw Sukh Singh as part of who's the ICB lead on this. We saw him as part of the task group, and he recognises the fact that we've got to improve. But it isn't only, David, as you all know, about GPs. It's about actually making the kind of consensus about having lots of different practitioners available within a GP community, within a GP surgery, for people to see and be referred to. And so as much as we need to continue to recruit GPs, and we have had some new ones starting in Medway and Swale, who've been sort of wrapped around by the ICB, helped with accommodation, helped with they've got mentors and peer supporters to help them settle, get their children into school, make sure that they're okay, make sure that they can find their way and navigate around the area. And I think we've got to widen that into a bigger programme. But the strategy isn't just about GPs, there's no doubt about that. It's about the different sorts of practitioners being able to work together. It's about building up the GP assistance grades, which has been done successfully in a few places, but not very many. It's absolutely about focusing on GPs becoming training GPs. We've only got 8 in Medway out of the roughly 38 practices. We could do with 15. And the barriers to that are many, and some of the GP practices say, well, trainees cost me too much money, so I'm not going to take them on. We've got to change that. We've got to work with the medical school, and it's been said to me that for as long as the training programmes are hospital-led, when trainees do their GP rotation, they don't get enough exposure to what it's like to be a GP. They only do 6 weeks. The emphasis should change. So I think there's several fronts that are happening within the ICB strategy about primary care that answer those issues. There isn't one single good thing that we can do that will change it. There are lots of things. And at government level, the GP contract itself, you know, it's very clear now that fewer and fewer people want to be a partner with a mortgage as part of the surgery. They want to be salaried. And this is why people stick to being locums. So I think there's a kind of paradigm shift that's needed in the way that we employ GPs and contract them to answer the more modern requirements. And I think we have to accept that not every GP, including new GPs and older GPs, want to work full-time, as they don't in other occupations. You know, that there needs to be a blend of different kinds of working hours. You know, some people who want to work in the evening, some people who want to work in the day, some people who want to work full and part-time. Bringing all of that together into a single strategy, I think, is happening. And when we had the GP task group, Suk shared his strategy with us and showed that there were elements of the things that we were doing in the task group that he felt could have been done better. So that's still a live issue. There isn't a definitive number of GPs that have been recruited to say that we're at sufficiency, because our population is changing all of the time. But it isn't something that people have taken their eye off in any way at all.
Thank you, Madam Chair, and thank you, Councillor Murray, for your report and for praising the voluntary organisations who are helping with the health and well-being. The first point I would like to raise is that from the way you've praised the voluntary organisations, I think it would have been appropriate if we put where we have the key facts and figures, if we could include the voluntary, because I can see that you've put in you've recognized institutions in on that page, and I think it would be brilliant if we have the voluntary sector also there. And my point is, I'll come from, we're talking about having the hypertension heroes, which I think is a very good idea, and myself being a chairman for the Ghanaian community. I think initially when we have these checks from voluntary organizations, when they do come, they do BMI, they do cholesterol, and they do the blood pressure. But lately, I think, well, because of the use of the hypertension heroes, when they can only do the blood pressure, which I think, what are your plans to equip them so that they can go further than just the blood pressure and maybe do the BMI and also do the cholesterol, so that we know that we've got a full report? Because most people from minority groups don't take the opportunity to go to see their GPs when it's time for them to go for their checkups and all those things. So what are the plans to include those cholesterol checkup and BMI into the work of the hypertension hero, so that we have a better, and then we are sure that when you go and do the check, you are covered?
Thank you, Councillor Anang, and absolutely right, wasn't it, to praise the work of the voluntary sector and not lose sight of the fact that we commission the voluntary sector to carry out services for us, and that's happening all of the time. On the wider health checks, of course, through our public health walk-in shop in Chatham, we provide those, and we do pop-up health checks with that longer session that you're describing. They're available all the time, and actually we've got capacity in some ways. I think there's consensus among James's team across the council that we need to encourage more people to take advantage of the ability of those health checks being available and taking on the different components, because actually that can save GPs time. People waiting for an appointment to go and have a checkup with a GP, they could just as well come to our own services, and we need to widen that as much as possible. So that's the first thing. And yes, I think, James, perhaps you can advise us on the extent to which the hypertension heroes could be extended to encourage those other things. Of course, if somebody is found to have high blood pressure, what will follow will be those additional checks anyway, whether they're advised to go for a longer health check with our public health team, or whether they're advised to go to the doctor. You know, but blood pressure is the first kind of flag that shows that something's going wrong, and you always need to move people on and make sure that they do more. But for this project, it was about the importance of blood pressure being an indicator that, you know, lots of things might be going wrong, and that lifestyles, even small lifestyle changes, can actually help. So that package of advice is there. And I think, James, it would be interesting to hear what you think about being able to extend that to things like BMI and cholesterol tests.
Thanks, Jeffrey. So the bit that we've just got to reflect on is the health check in itself. So I think we're talking about the NHS health check, although as Councillor Murray sort of stated, we can do other checks like that for people who potentially might have a problem but don't realise that through some of our outreach. So we actually commission those services and we provide them in-house as well. You've got to have a level of training, particularly if you're taking people's bloods. The Hypertension Heroes programme is dedicated around hypertension because of the risk factors related to ethnicity and then an increased likelihood or risk factor for stroke. So that's why we focus on that particular area. But there are, within the Hypertension Heroes, as you're probably aware, there are people who are clinically qualified. We've got retired doctors and things like this. So we can reflect on that and see whether there is something around there. But what I don't want to do is to dilute the focus on the NHS Health Check programme that's quite comprehensive. And one of the other things is when people go through those checks, the data goes immediately into the GP record because of the software systems that we use. If you're out and about doing Hypertension Heroes and those types of checks, they're not using the same software, so we probably don't want to duplicate. And as Councillor Murray stated, that the heroes will signpost people if they've identified that they have got high blood pressure, other risk factors, because they do a lifestyle screen, into those services where they can get more specialist support. That would probably be the most safer way for us to do that, but we can explore some of those alternatives as well.
Do you want to come back in, Councillor Ang?
Oh, because the reason why I'm raising that issue is that those times when we have a community event, we do get the NHSF checks coming around to come and do full screening to check the cholesterol and everything. But because of that hypertension heroes, when they come now, they just do their blood pressure. So, you know, so now we are losing the NHS checks when we're having events because the hypertension heroes come in and they only do the blood pressure. So then we lose the BMI and the cholesterol checks. So that's why I'm raising that issue. So do we go for the NHS check or do we go for the hypertension heroes when we're having events?
Thank you. And I mean, so it's a quandary there. And I would say that what we'd probably need to do is just have a conversation offline to have a look at the nature of the event. Because if it's sizable enough and there are significant people there, then we can try and deploy some additional resources to make sure that you get a more comprehensive intervention. But I would say that it's not an and or. I think, I'd really value the fact that people are coming forward and at least getting the blood pressures checked. That's a real positive. And if they then get identified with an issue, they can always, as we've already said, our high street shop, it's there, it's open, people can book into that if they want to. But I will pick up the point that you raised in terms of community events and see what the support we might be able to provide in that kind of sense.
You're happy with that, Councillor Lang? Take that off. So finally, Councillor Hamadashi.
Thank you very much. And I want to make this one count. And I want to bring together James and the consensus view about digital tools to talk about mental health and the reality of self-management, which you talk heavily in the report, which I do welcome indeed. The reality of self-management for people with mental health is literally, you might see your support worker, your carer, for 30 minutes per week. That equates to 1 hour per month. That equates to 1 day out of 365 days that make up the year. So for the rest of the time, these people are self-managing, and a lot of them are relying heavily on friends, family, volunteer services, as well as health apps that manage things such as depression, anxiety, and whatnot. And the point I want to raise is, at the moment, on the Google Store alone, they have 54,000 of these health apps out there. If you go to the NHS App Store, there's over 75 apps. And I was supporting a young person that was relying on one of these apps that turned into a zombie app, meaning it was defunct. And they had put all their personal feelings, their coping strategies into these apps. And that data doesn't go back into the hospital system, it's just dead. So can we get your assurance that you push this to be included in the digital technology strategy, to be looked into? How can we recommend apps that actually are worth their weight in gold and they can actually add real value? And how can we signpost service users where they can get access to the better resources?
that's a really good point and something that we need to do. There's nothing more disappointing and demoralising to find yourself in the position that you've just described, where you've sort of put your heart and soul and your trust into something and then find that it isn't there anymore. I think, Jackie, that's a message for you to take back for that strategy, you know, actually recommending things that we know work and promoting them. Not to replace the face-to-face contact, but I think the context that you've described there, Douglas, really made a mark on me. It might sound like a lot, seeing somebody once a week, but actually in the context of a whole year, it's not very much at all. So being able to give people other tools to rely on, like an app that they can reliably use that will help them, I think that's really important. So that's one, I think, for us to take back, Jackie.
Thank you. So thank you very much, members, for the questions. Thank you, Councillor Murray, for coming in and answering them. I support my colleagues have all said about the excellent report, and I welcome the work that's been done, in particularly for women's health and the menopause, and I look forward to the women's health hubs. Thank you very much. Over to you, Vice Chair.
I move that we note and thank the Deputy Leader for her attendance and note the report.
That's seconded. Agreed.
Agreed.
We are moving on to item 7, which is the Kent and Medway NHS and Social Care Partnership Trust briefing 2023 to 2026. Councillor Hamadashi is excused. Welcome, Adrian and Sheila. Thank you for coming. If you'd like to go ahead when you're ready. You can take it as read that the members have read your report.
Thank you, Chair. Good evening again. Today we're bringing back a paper at the request following our August attendance at the committee, outlining different themes that you'd like us to present over the course of the next few months. Following the agenda setting meeting earlier this month, we were asked to come back with an update on our strategy, and the paper is attached. Obviously, I'll take it as read. The paper originally outlines the previous strategy of the 2020-2023 strategy, where we looked at 3 aims, that of quality, integration, using our expertise to lead. It also provides some examples of the deliverables from that strategy. It also details some key learnings, and that basically is on measurability and how we can measure a strategy and the progress towards the strategy. And we've incorporated that learning into the 23 strategy, as the paper details. At the beginning of this year, we started to design our new strategy based on the 3 Ps of our strategic ambitions: the patients we care for, the people who work for us, and our partners that we work with. Alongside that, 3 enablers of digital, sustainability, and infrastructure. During that creation period, we consulted with a number of senior leaders. Around 75 of our senior leadership team were consulted and had direct input into the making of that strategy, along with our engagement council and our engagement pool, which consists of around 150 patients, service users and carers who had direct input and direct feedback to the board before we finalised the 2023 strategy at our board in March of this year. The paper also talks about how we have communicated and engaged internally and externally, and predominantly within the internal mechanisms using cascading through the organisation, and I won't go into details of the details contained in the paper. We also engaged externally with a number of our stakeholders, our providers across Kent and Medway, our healthcare partnership boards, our integrated care board and other agencies, and in fact actually our strategy also tied into the joint forward plan that was drafted and submitted by the Intermediate Care Board to Centre around May of this year as well. So we lined both of those strategies up to make sure that they sort of met the needs of the population. The paper finally also talks about how we continually monitor and are reviewing our strategy, we've recognised that there was over 70 outcomes that we want to achieve. And that's a number of outcomes that would pose very difficult for all of our frontline teams to understand and to really know how they can contribute to over 70 different outcomes. So we've phased this strategy over the course of the next 3 years in three different phases. And the first phase this year covers around 18 of the 70-odd outcomes that we want to achieve, and they are the key priorities for the organisation. One is flow, getting our patients into the services that they need in a timely manner, and then when they no longer need to be in those services, how we get them out and work collaboratively to get them out. The second is on dementia and making sure that we give patients the access to the diagnosis and then tie them into the further ongoing care when needed as well. The third is on community mental health transformation and our transformation, making sure that we transform our community mental health services to be fit for purpose for the next number of years. The fourth is on violence, aggression and racism, and reducing those elements within the organisation and what our staff and our people are subjected to. And the fifth one being retention and recruitment, making sure that we have enough workforce fit for what we need, and making sure that when we do recruit, we retain those. So we're asking our staff and the entire organisation to come together on those 5 themes for this year. And as those 5 themes as we start to achieve those 5 themes, we will then phase in phase 2 and then phase 3 of the ongoing strategy. The report also talks about the governance, and it gives details with regards to the monthly review and monitoring through our strategy deployment group, our transformation group, and then subsequently reporting into to our board subcommittees, namely our quality, finance, and our workforce committees as well. And I think finally, on a personal note, we have found over the last few months staff to really want to start to engage with the new strategy, to really help to really gain an understanding of how they are individually contributing to that, and the power of 3,500 people to deliver the strategy, we're really sort of starting to harness. So I'll pause there and we're happy to take questions. I do apologise, forgot to introduce, on my left is Sheila Stenson, who is accompanying me tonight. She is our Chief Financial Officer and Deputy Chief Executive for KMPT.
Thank you, Adrian. Welcome again, Sheila. So we'll further open to questions, members. Councillor Brake.
Good evening, and thank you very much for your report, which I found and I always find extremely interesting to read through. The first section of the report actually talks about staff, and the fact is that there's an awful lot of information about your staff. It refers to who they are, where they come from, the diversity of staff. It's extremely good. It gives a very good background. However, what I don't see, I do beg your pardon, that's one of the reasons I was quickly brushing through this, but it does actually quote the number of people, I think it's 4,000 or so members of staff that are employed by KMPT. But that really is the only reference that I could find, unless I've missed something completely, it's the only reference that is given to the number of staff employed. What it doesn't do, in fact, is to tell us of those staff that are employed, what is the staff turnover at all levels? And here I'm talking about from the chief executive right the way through the whole system of people who actually care for the patients and on a day-to-day basis, right the way through those that provide administration, maintenance support, all of those sorts of ancillary posts. So what is the total situation? This really does try to paint a very good picture of the staff. And when I look at the diversity and all that goes with it, 4,000 people, it does point that out. But what it doesn't tell me is, A, what's the staff turnover? And that's the information I'd like, please. Staff turnover at all levels, from the executive right the way through the whole system. And secondly, what is being done to retain members of staff, please?
So with regards to some of the data that where we are currently, our turnover sits for June and July sits at around 18% for Medway, 18%. Which is comparable to the rest of Kent and Medway or KMPT's areas that we cover. We have actually seen a reduction in the last 3 months with regards to staff turnover, and we are hopeful that that will continue as well. A number of the staff turnover metrics that you're referring to are monitored through our monthly, our business as usual quality performance reviews as well. So we monitor that through that perspective.
Sorry, so you're saying that on the last count it was 18% turnover for that month. Is that 18% on a monthly basis, or so therefore what is the turnover per year?
So I don't have that workforce data available this evening, but I'm more than happy to supply it afterwards.
Is 18% a sort of average figure for the on a monthly basis, or what is it?
So nationally, 18%. 18% is nationally puts KMPT in terms of the mental health providers middle of the road in terms of turnover. It's still higher than we would like, and we want to make sure that we gain high quality staff and we retain them for as long as possible. But in terms of where we are in terms of the national picture, we're fairly middle of the road in terms of that. But as I say, we are seeing early signs of a reduction in that in the last couple of months as well.
Okay. So is there a strategy to improve upon that? And if so, what is the strategy?
So there is a plan. We only have one strategy at KMPT, and that's the overall organisational strategy. But within the outcomes under the people that work for us, a number of them include retention and recruitment programmes. So there are plans that feed into that, both globally within KMPT, but also locally in terms of different teams and different directorates as well.
Thank you. And the final point, if I may, that 18% is an overall figure. But what about the hierarchy, the executive level of KMPT? Where are we today? Who is in charge of KMPT? What's the organisation, and how long have they been in post, please?
Sure.
I'm happy to pick that up. So Helen Greatorex is obviously currently our chief exec. She retires at the end of October, so I'm the incoming chief exec and I start on the 1st of November. I've been with KMPT 6 years next month, so I'm probably one of our longest serving executives. So in terms of our Chief People Officer, she's been with us probably the longest out of all of us, so probably just 7.5 years. Adrian joined us in March this year. And in terms of our Chief Nurse and our Chief Operating Officer, they've been with us 18 months. So we have got a stability in our executive team, obviously with Helen leaving, but me being an employee of the Trust as well. I obviously know KMPT very well after the last 6 years that I've spent in the organisation as its Chief Finance and Resources Officer. So there is stability at exec level.
Councillor Wilding.
Thank you. I had similar questions, which is never helpful when you follow. But if I can go back to the 18% in, I wasn't sure whether you meant 1 or 2 months, but if you take it at 2 months and then you put that over a year, there's over 100% turnover per year, which, you know, you would know if you was running it at that sort of rate, or are those figures, or my working out, misleading?
So I think we do just count that on a monthly basis, so that won't be a cumulative over a year. But what I'm more than happy to do is actually get detailed calculations and the trend for the committee as well.
So that 18 months would be from January, I assume, up until June, July, not for the last 2 months. If you could send us the figures, that would clarify, because I'm sure there's misunderstanding between us. And again, on the papers we had last time, the way I read them, the top 4 officers were changing, which again has been covered, but that's never helpful for consistency, etc. I've got your previous job title, but you're moving up, so obviously someone's got to step into your shoes. And if they're in-house, again, their role needs replacing, except so these things do have a knock-on effect. The one other thing on staffing, I didn't see anything in here about staff feeling bullied, which, as far as I can remember, hasn't been a problem for KMPT, but it has for some other, CCAM in particular, but other organisations. Has bullying and your staff ever been a problem?
So we acknowledge that we've got lots of work to do with our workforce in terms of our equality, diversity and inclusion. Pieces of work which we're just kicking off this week, and next week we're holding a senior leadership conference on that. We also acknowledge that there are some really good pockets of work that are going on across KMPT, looking at supporting staff and things. We also monitor the bullying through our Freedom to Speak Up service, which is our independently appointed service where staff, if they feel that they have an issue, that they can go to the Freedom to Speak Up Guardian, and that reports into the Trust Board twice a year. We also obviously will monitor the any through our annual staff survey any instance of bullying, so people can report that from there. We don't believe that we have a problem with particularly bullying within the organisation, but there are a number of opportunities that we want to improve on with regards to both our violence and aggression that our staff experience, but also racism across the organisation as well.
Right. I think it's 4.4, if I remember correctly. Yes, the top bullet points, you talk about reducing the number of people being detained by Section 136. We did have a pilot, or you had a pilot, mental health nurses going out with the police in a joint car, and that worked extremely well by all the figures we were told and everything that came back. As that was so effective, why has that not been continued?
So I can answer that to a degree. I think some of the urgent and emergency care transformation that sits with regards to mental health sits with the ICB as opposed to KMPT. But what I can say is that there is a huge amount of work under the urgent and emergency care pathway, which sits, as I say, sits with the ICB, looking at alternatives and different ways of working. And that programme of work has started to come online. There are a number of different initiatives that are currently being planned and that are underway, and KMPT are helping with those, and where possible we are facilitating them. But some of that work does sit with the ICB.
But is that method being looked at as far as you're aware?
So as far as I'm aware, that was one of the areas that's been considered, but there are a raft of other new initiatives that are coming online over the course of the next 6 months, particularly to come online to help with the winter period and forward from there.
And lastly, if I may, on dementia and Alzheimer care, you're still closing Ruby Ward. Again, last time we was told about the shortage of beds for those type of patients, but you're still closing the Medway provision.
Is it a question, are you still closing the Medway provision? Yeah.
Well, yes.
We did cover some of this last time, but the Ruby Ward is moving from a Medway site to Maidstone in a purpose-built facility. I have and I will continue to extend the invite to anybody on the committee who would like to come and see the new facility. We are continuing to look at how we can make sure that unit is going to be the best level of care for our patients in the older age psychiatry area. Ruby Ward, where it currently is sitting within Medway, is closing. It is a not fit for purpose unit at the moment, and we want to make sure that we can provide the most up-to-date and most high level of care that we can for our patients.
Now, that sounds fine, but if there's a shortage of beds and you find them fit to use at the present, then surely until there's enough beds, at least, and a provision in Medway, they should continue.
So while we have some beds that are currently being used, they are below what we want to provide our patients. So the decision was made a number of years ago, or a couple of years ago, to move Ruby Ward to the Maidstone site. What we have done is we need to make sure that we have the right number of staff for those beds that we need, and where we say that we have a shortage of beds, we have a shortage of beds from, and as I explained previously, there are multifactorial reasons for beds. On Monday, we had 50 of our 250 bed stock, which was occupied by patients who were clinically ready for discharge. Now, if we had those 50 out, we would have sufficient bed stock and be able to bring back in all of our, some of our out of areas patients to provide that care close to home where we want our patients to receive that care.
Thank you. But
Thank you, Adrian. I think Jackie's just going to come in there, Councillor Wiley.
Can I just, but the fact is those beds aren't freed up, so people need the provision. But sorry, if Jackie wants. Sorry, yeah.
That's fine, thank you. I think I just want to talk from a partnership point of view about the challenges in the health and social care system, and I'm not dismissing or recognising your concerns. I'm attending meetings regularly with the KMPT colleagues and the ICB about the challenges that there are in the ability to move people from mental health beds into the community. And we've talked about the local account, and we've talked about the challenges with waiting lists, you know, in the past. We've got significant pressures in Medway, and there are significant pressures in Kent with regard to care home beds. And so it's very difficult for us to be able to move people when they are, I'll use the old term, medically fit for discharge, into a care home. And so actually, when we talk about in the old money, delayed transfers of care, there is a pressure because we can't move people out. So there's a lot of work that's taking place at the moment. There's a meeting coming up. I'm looking at Louise, but I can't remember what date it is, but there's a meeting coming up when Medway, KCC, the ICB and KMPT are working together to look at what can we do as a system to support people who suffer with ill mental health that no longer need to be in a mental health bed and can be living in the community, but the social care pressures are having an impact on them. So I'm not disregarding your comment about Ruby Ward, etc., but if we were able to resource social care better, that would help our partners.
Thank you, Jackie.
May I come back on that?
Just quickly, Councillor Hardy.
But the fact is that provision isn't there. There are people that need to be in those beds, and we are closing and taking the provision out of Medway of, I believe, 16 beds.
So I can't comment on that. That's a decision that's been made. But what I want to be really clear about is what are we doing as a system? What is adult social care doing? If we were able to move people out of the beds, then there wouldn't be a problem. That's across the board. That's not just with KMPT. That's with MFT. We've got people waiting to be discharged from hospital. We've got people in the community. I just want to be clear that it is a broader issue across the health and social care system, not disputing your comments.
Go ahead, Sheila.
Thank you. I just wanted to kind of come back on the Ruby thing, and I know Adrian would have covered this with you last time. So we flex beds at Ruby Ward currently within MFT between 10 and 14 beds at any point in time. The new unit of Ruby at Maidstone is going to have 16 beds. So I do appreciate it's not in Medway, but actually I know, as Adrian would have covered with you last time, there's been that national initiative around dormitory wards, and actually Ruby is sadly the only dormitory ward that we have left, hence why we have gone for the kind of new build at Maidstone. I have had the privilege of going round it. It's not quite finished yet. It will be finished by the end of November. We're hoping to take it back from the builders at that point and then open it very early in the calendar year. But as Adrian said, we are happy for anyone who would like to come and visit that ward. It is absolutely it will transform patient care. The ultimate thing for us as well is the ward is on one level. It's on the lower ground as well, which it should be for older adults. So please just take us up on that offer. We're happy for anyone to look round.
Thank you, Sheila. I will be taking up on that offer. I'm interested to see it. Councillor Prenter.
Thank you. Just reading through your strategy, I looked at your sustainability and you've got a big bold sign there, net zero, so you're going for the best that you can, which is net zero. And I'm glad you've included people who work for us, because without them, you don't have an organisation. But I'm just have concerns over the statement here. Our minority ethnic staff are treated equally, experience less racist violence and aggression and feel safer. Considering you have a workforce from 66 countries, I know since 2016 it's on the rise, racist behaviour, but I would have hoped that in your strategy document you'd have had a better statement than just less, because if that means one less member of staff receives racist, aggressive behaviour, violence, you've achieved your strategy. So I would have rather have seen better language around that.
Thank you, Councillor. Yes, you're absolutely right. We take that on board. What we have done is, what you don't see that sits underneath this is a monthly reporting mechanism. So actually, as an executive, one less is not acceptable. It is unacceptable that any of our staff come to work and are subjected to racism or any form of abuse. So that trajectory will be set. And if we achieve it in 6 months, a 10% reduction, we are not going to stop there, because we want to make sure that we are as free from racism as possible as an organisation. So we have that commitment from the executive, you have that commitment from the board, you have that commitment from the senior leadership of the organisation, that one isn't ever going to be enough. We will not stop until, I will not stop until we have a zero.
Councillor Cook.
Thank you. I found it really helpful to read the briefing document and then your strategy document together, because what I actually did, and it really stems from what Councillor Prenter's just said, I read the briefing document, then I read the strategy document, then I thought, that's going to need a lot of governance. Then I went back and read again. And I think it is that question around baselines, because all the way through, you've got some real numerically driven targets. You've just outlined how you're splitting those over different priorities for different years. I think you spoke in the briefing paper about delegated committees, and you've just mentioned part of what I was going to ask, which was a kind of reporting metric document. But I had a very similar question there around starting points, because it's quite hard for us looking at the whole strategy, which I recognise will come back to various points, as has been spoken about today, of that strategy, to look at those finer details, to say, actually, where are we now? Where are we going to be, and how quickly? And is that an ambitious enough target? Because I think similar to that conversation we've just had, vitally important about racism, the one that jumped out to me on page 99 is about reducing suicide and self-harm. And again, it's, well, what is a reduction? And I know, you've just said you've got some real metrics there. It'd be really interesting to see what that document will look like. Is that baseline data all in place? And does that document then have next to it when those benchmarks are going to be hit? Thank you.
So yes, underneath this there is a number of documents that do sit, and we have benchmark over the course of the year 1, year 2, year 3. You're absolutely right. Some of these metrics are have had to be looked into as to where we get them, because although we are a data-rich industry, we are sometimes an information-poor industry as well. And so it's really important that we make sure that we pull together what those data sets are, where that data is, to bring it all into one place. As I say, we've marked it out in terms of year 1, year 2, year 3. Our next step is now to actually say, how we're going to set that trajectory. I think I said last time, we're not going to have a linear trajectory, because you're never going to be able to do that when you're trying to drive improvement. It's a much more normally a logarithmic sort of level of improvement that you'll see the very small turning of the dial for the first few months, and then it will start ramping up as we learn from that, and we ramp up all that learning into something much more bigger. So yeah, underneath that there is a firmer set of trajectories that we will be working on.
Thank you. So yeah, just to say as well, and we debated this a lot when we were doing the strategy. So as Adrian's just said, lots of data, but is it really going to tell us how? I think when we look back at the last strategy, we wasn't able to tell the story around the outcomes and the difference it had made, which is why we spent quite a bit of time this time looking at that and thinking, how is this really going to make a difference to our patients? So I would love to say that all the data is available. Some of it now we're trying to still gather, so we've got a really clear baseline. Some is easy to do because we have it readily available. Some is about how we work with our partners so that we've got the data available as well, so we can absolutely measure. If I think about we've been ambitious and said we would love to get to 85% bed occupancy. We know that's not going to happen in year 1, so we've said that will happen by year 3. So we've got a very clear patient flow plan and how we will get to 85%. Obviously there is risk involved in that, but that is us kind of looking over the 3-year course thinking, here's where we are now, about 96, maybe some cases 98% bed occupancy, but how can we realistically get to 85? And we absolutely know that's going to be year 3 because it's going to take us that time.
Thank you, Councillor Brown. Councillor
Sorry, the question I was going to ask I think has already been asked.
Thank you.
I believe I'm last, so as I'm one of the only 2 councillors that remember KMPT before Helen, can I say, obviously I've got problems with KMPT, but to thank Helen because it's 10 times better as an organisation than when she started, and I think we as a committee should acknowledge that. But as I say, yes, I'm one of the few that remember before, so thank you to her. But I'm not going to be polite or nice to you again, so thank you.
Thank you. We will pass that on to her.
We're always polite. Thank you, Adrian and Sheila, for coming. Thank you, everyone, for your questions. I'll move to the Vice Chair.
I move that we note the report.
Is that seconded? Agreed? Thank you very much. We're going to stop for a 5-minute comfort break, but just before we do, I wanted to highlight, and I didn't a little bit earlier, Councillor Crozer, in the annual public health report in 2021 that is available on the council website, there are a lot of answers to your questions about digital statistics. So hopefully you'll be able to find some answers in there as well if you wanted to know quicker. All right, that's it. Let's have a 5-minute break. Thank you. Thank you. So the next item is item 8. Emergency service transfer of Medway and Swale TIA service. And we welcome Stephen Fenlon. Welcome, Stephen. So, Stephen, you can take the report as read, and over to you.
Thank you, Chair. Shall I provide a brief introduction? Is that okay? So first of all, just to apologise, Justin has been called away for a family issue, so I'll be presenting and taking questions on my own. So the report is an update from August, as requested by the committee. I will, as you've said, take it as read. Perhaps I should just emphasise that I do want to be clear. Running through the report is a thing that everybody is working very hard on trying to deliver what the committee wants to be what's seen done, and we are continuing our regular meetings with the full engagement of the clinicians across the piece. So that side of things is continuing underneath all of this, but the report sets out things as they currently stand. So I'm very happy to take questions. Thanks, Chair.
Open to members. Questions? Councillor Wilding.
Thank you. The report doesn't really take us very much further than the last report. I do understand it was only a month-ish ago. Our concerns, I'm sure, will all remain the same. I know mine do. I'm not sure that it's been taken on board that this was put in Medway or kept or at Medway MFT as mitigation for the stroke reviews making the wrong decision. So I do think that should be taken into account. And with that in mind, I know the reasons, but I still don't think it should have been taken out of MFT. But, you know, we are where we are, and you had to do what you had to do. But
have you got a question, Councillor Wilding?
I'm terrible at not giving questions, aren't I?
Now's your chance.
The answer's no, basically. Thank you.
Thank you. And it's just to reinforce any concerns. James's team has been working with Stephen's team to try and get forward on this. So over to Councillor
So I'm new to the committee. I'm one of the newcomers, so I don't know if this has been addressed before and I'm going over it. But I'm curious about what travel assistance is available for people to bridge that gap. I think it mentions that there is some assistance available. But more importantly, how have you assessed the impact of this extra travel? Because I was looking up the symptoms of TIA. It's pretty serious. It's very serious. And it says very clearly when I read on the NHS website that early intervention when that TIA is suspected significantly reduces the chances of a full stroke from happening further down the line. So that sort of immediate, recourse to help. So how are you assessing the impact of that travel, and what are you going to do to mitigate that? And I would also like to know when this service will be brought back to Medway.
Thank you. I think there's two questions in there. Is the perhaps the impact of the travel on people having to travel. So how do we assist with that? So there is some information in there about that. So people can be given assistance to travel if they need it. If they don't have means of travel themselves, then they will be helped. The impact on the patients receiving the clinical service. So you're absolutely right. TIA, I think I may have talked a little bit about this last time. The TIA is, if you like, an early warning. It's not a stroke, and by its nature, it comes and goes. But the good thing is to pick it up, and then it can be used as a preventative for future worsened condition into a stroke. So the point of a TIA referral is to get patients onto that preventative pathway. So there is some treatment and some prevention elements as a result of TIA. The patients are generally referred usually by their GP. So the patient will present to the GP. The GP will then refer into the TIA service, and then the patients are contacted by the TIA service. That's always the way it has been, and history is taken from the patient to try to ascertain exactly what is wrong with them, and then to also formulate how urgent it is, because it's not all the same. Some are more urgent than others. And then on the basis of that, then a decision will be made about what sort of investigations are needed and what the next steps are. I'm not a stroke clinician, so I'm very wary of stepping into things that I don't fully know. But my understanding is that treatment can be started at that point, and then further investigations will be started at the same time. And that will then determine what the future treatment might be. Because, again, not all the treatments are going to be the same, so that's why there is a step of investigations that are needed. I would hesitate to say that adding a journey, an additional journey, should not jeopardise the treatment, because the treatment can be given anyway, wherever the patient is. What we're trying to do, of course, is to try to localise that investigation pathway so that people don't have to travel so far for their treatment. So they access the stroke expertise, they access the advice, and they can access the treatment as they always have done. But what we've discussed before in the previous meeting is that they will unfortunately have to travel for their diagnostic part, for their imaging, echoes, etc. And we are trying to formulate, and the group is working to formulate a way of bringing that back so that they don't have to do that. I'm giving you a very long answer. I'm not sure if I've fully answered your question, but
So, thank you for that. Just to clarify my own understanding, so if a person goes to the GP presenting the symptoms of TIA, and the GP refers them to the service, and then this patient then has to potentially travel to this external centre outside of Medway for scans and assessments, and then a decision is made about the treatment route, which is then passed back to the GP. Is that what you're saying? And then that treatment is delivered locally through the GP?
It may well be, it may not. There may be other treatments. So there are some surgical treatments as well as a result of TIA. So patients can have, for want of a better expression, some furring of the arteries in the neck. That may actually require surgical treatment. And that's not done in any of our hospitals. That's a highly specialist treatment that they would be referred on for. So again, I'm really conscious I'm stepping outside my expertise.
So we could be looking at multiple trips that people have to make outside of Medway through the course of this. And when you say help will be provided, is that physically that your service basically organises a car for them
Yes,
to travel?
they can.
Okay.
Yeah, we're working as a system, as you heard before. So we can work with people in Medway, voluntary sector in Medway. So we have there's a network that can provide support to patients if they need it. They will be offered it.
Okay, thank you.
It was just to confirm this is the follow-up appointments, isn't it, that they're travelling over to Maidstone for? Councillor Brown.
Thank you, Chair. Thank you for this report. And I want to pick up sections 3.9 and 3.10, particularly 3.10 actually, which says basically that the Kent and Medway ISDN established a multi-stakeholder working group to complete the emergency service transfer, and this group continues to function to ensure that the pathways are operating as expected. To address any issues that emerge, including patient feedback, monitoring expected referral numbers, and to explore how the future model will be provided. Now, there's a section 3.9 says that the proposal will be brought to the programme board on the 31st of January. My questions are around the patient feedback, the level of monitoring, and what consideration is being given for the future model to bring this service back to Medway. I think that question was asked by Councillor Campbell as well, but not maybe in the level of detail that I'm asking for it in. These two paragraphs seem to be sort of contradictory, because if you're going to do the feedback, I'd like to know how much of it's happening now, and I'd like to know what kind of open and transparent discussion is there about this service coming back to Medway.
Thank you. So the meetings that are talked about in 3.10 These are the meetings that have been set up as a consequence of the change in the TIA pathway. So they're fortnightly meetings, and they include representatives from the service within the North West Kent area. The reason we've created that is exactly as you said there, is twofold. One is to work on the solution and creating a better pathway, but the other is to monitor the existing situation. And so we are collecting patient feedback, and we are looking at the resolving issues as they arise and supporting clinicians and making sure that we are dealing with the issues as they come up. We wouldn't normally want to bring people out of their workplace every fortnight for a meeting, but clearly because there are a lot of things happening here, we're using this as a format to make sure that we stay on top of that. The other thing that we are monitoring is to ensure that we are seeing what we would expect to see with patient numbers. So in other words, that we're seeing them across all of the hospitals, or all the areas that we would expect to see.
Thanks for that. So, just from my understanding, you're having fortnightly meetings at which you are looking at the figures around feedback and the referral numbers in the hopes of producing a model within the next couple of months, obviously, if you're going to report to yourselves on the 31st of January. Yeah. Okay. And to answer Smita's question around the support for travel, who's providing it and what format does it take and how do people get referred to it? Thank you.
Can I take that question away, because I genuinely don't know the answer to that one. But
Yes, please. If you could provide an answer, that would be helpful. Councillor Hamandashi.
Thank you very much. My question is more to do with the risk associated with your analysis. If you look at, I know 5.1, but you give reference to section 3, and you refer to relevant impact assessments. I just need some assurances that when we talk about risks and we're using various tools, that you make those tools known to the group, what tools, both for the service to map your risks and also patient-facing. And also, more importantly, what are you going to be doing to mitigate those risks once you've identified them?
Thank you. So the purpose of looking at those risks is to report into the group described in 3.9, which is the Integrated Stroke Delivery Network. That group is responsible for the whole of stroke care across Kent and Medway. So this group will be accountable into them, providing that information to them, because they want to see that everybody receiving adequate and appropriate stroke care of all sorts across Kent and Medway. So that's the purpose of looking at the risks. So we're not reporting it back to ourselves, we're reporting it into that group. And that group does include representation from colleagues from Medway.
Sure. So my question was in terms of the risk tool that you're going to be using, because you can cover up a lot in the narrative, but we want to know what tool you'll be using to categorize these risks.
Yeah, my misunderstanding. So there are a number of, for want of a better expression, targets around TIA treatment and other stroke treatment as well. And that's nationally collected, so we can measure and benchmark against those things.
Thank you.
So I'd just like to say, obviously, we all want to see the service brought back to Medway. That's a given. You didn't have any sort of estimation when Councillor Campbell asked you when that might likely be. Do you have any ideas? Anything come since the last time you've been to sort of encourage a date?
So our if you like, our deadline is that meeting, the ISDN in January. That's where we will propose bringing the solutions there for that group to consider. So I can't give you a date beyond that date, but that's where we would propose to take the answers that we can create within the time we have. But there are, as we discussed last time, there are a number of things that we need to align as part of that, and that will hopefully all come together at that point, and then we can be a little bit more firm about the understanding we can give you.
Thank you. And I was just going to ask as well, I know it hasn't been that long since for you to be able to measure this, but have you seen an increase in wait times now that Medway patients are having to go to Maidstone? Because obviously there's more patients accessing the same resources. So has it had a detrimental effect on all patients that use that service? Thank you.
So I've attended most of the meetings, and we've not had that issue raised to us during most of the meetings that I've been to. But we are, the last two meetings, we've been collating data, and we are going to bring that back. So we can provide that to the ISDN, or I can bring that back as a separate issue to the committee so that we can provide some assurance on
Yes,
wait
please
times.
do bring it back. I'd like to know whether our residents here are having a less of a service, although we know they are because they're having to travel, but in terms of wait times. Unless there's any other questions from members, I'll move forward to... Sorry, Councillor Wildy.
That information comes in a briefing note in the first instance, if that's going to be sooner than waiting, you know, for a committee meeting for it to be put on the agenda.
Is that possible for you to be able to... Can we ask for that to happen, please?
What does that mean? I'm sorry, I don't understand.
So just that you send it to us in a written form, email, because the next agenda meeting you might be invited to might be 3 months down the line. If you've got the information in 6 weeks, we prefer it earlier.
That's fine, yeah.
Is that... And you send it to Michael, and Michael sends it out. Right, thank you.
Okay, we'll move forward. Thank you very much, Stephen, for the update. We'll just move forward to the Vice Chair.
I move that we note the report and request an update at the March meeting, ask the ICB to inform the Director of People and Deputy Chief Executive of the proposal on the future of the TIA service, prior to this being considered at the Integrated Stroke Delivery Network Programme Board on the 31st of January, delegate authority to the Director of People and Deputy Chief Executive to submit comments on the proposal to the ISDN Programme Board, following consultation with the Chairperson, Vice Chairperson and Opposition spokespersons.
Is that seconded? Agreed? Thank you. Thank you, Stephen. Thank you, members, for questions. Moving forward to item 9, section 136 pathway and health-based place of safety service improvement. Welcome, Louise. Thank you for your patience in waiting this evening. You can take your report as read, and over to you.
Okay, thank you. Thank you for having me this evening. I'm returning this evening to update the committee on the decision made by the ICB on September 5th in their ICB board. And that was to approve the Section 136 pathway and health-based place of safety service improvement. The decision-making business case was signed off by the board, and the design phase has now commenced, which is being done co-productively with a broad range of stakeholders and lived experience experts. This service improvement sits within a wider programme of improvements to the urgent and emergency mental health pathway. And I'm very pleased today to update the committee that we have awarded Hestia, a third sector provider, the contract for a 5-bedded crisis house for Medway.
Apologies, Councillor Brown has an interest as an employee of Hestia, so he's going to leave the room.
Thank you.
So just wait for it to leave, and then you may continue.
That's okay. Hestia will be providing a 5-bedded crisis house in Medway from December, and Mental Health Matters is providing currently a safe haven in Medway. We've moved it to the Medway Foundation Trust hospital site. It sits within the car park. On last Friday, we extended the open hours from midday to midnight, and from April, the hours will be 24/7.
Thank you very much. Members? Councillor Campbell?
Thank you, Chair. So just again, to clarify my understanding, so you are you're centralising this Section 136 pathway, but this Medway 5-bed provision is separate to that? That is in addition to what you're doing?
It is separate. It is separate, but the reason that I refer to it is because currently police officers will use their powers of Section 136 to remove someone to a health-based place of safety, sometimes in the absence of there not being alternative facilities available. So we've already managed to reduce the instance of Section 136 within Kent and Medway. We were an outlier at one point through the provision of a clinical advice line for Kent Police. So on happening upon an individual in a place the public have access to, they can seek direct clinical advice from a mental health clinician and think about alternatives to detention under 136, and that facility has reduced 136s. But the reason it's important to mention the safe haven in Medway and the crisis house in Medway is because these provide alternative community crisis provisions for individuals in mental health crisis and may well support the police in not having to use their powers of detention. There are no health-based places of safety in Medway currently. There are 5 health-based places of safety within Kent and Medway spread across 3 sites, Canterbury, Maidstone, Dartford, and what we're doing is centralising those 5 places into one place, which is in Maidstone.
Okay, so the crisis centre and the safe places, that comes before the Section 136. It's to stop people getting there. Okay, yeah. That makes sense. So what happens to did you say 5 centres that you're kind of integrating into one unit? So what happens to those centres, their staff, their expertise, and do you see any risks in the transition process?
So when we talk about 5 centres, what we're actually talking about are 5 assessment rooms. They're currently spread across, as I've said, 3 hospital sites. So there's one room in Littlebrook Hospital. It's a room with a shower facility available and a small room for the nursing staff. In Priority House, it's 2 rooms in the same layout, and in Canterbury, it's 2 rooms, and it's a very small team of staff within each of these spaces, and we've had difficulty actually retaining staff in those spaces because, firstly, they're very small teams. We can only accommodate 2 people at any one time, and so those teams are often having to do a lot of unsocial hours, and there isn't sort of room for career growth and development. So actually there's been a very positive response from the small teams that are working on the 3 sites currently. They're looking forward to working in a bigger environment, a more fit for purpose environment, and being part of a bigger team will be much better in terms of shift patterns and career development.
So are you expecting that those staff members to relocate then?
We are, yes.
Okay.
Thank you. Councillor Wildey.
Thank you. It's very good news about the MFT site. It's a shame it can't be a place of safety. And you probably heard earlier, I was talking about the mental health nurses, police in a car as a pilot. Now that had very good results, so we were told, and that doesn't seem to be considered. Was that too expensive, too difficult to get a member of staff to go out with the police? Did the police not welcome that? Why are we not taking that forward?
Yeah, so my memory might be sketchy thinking back to that time, Councillor, but I know that there was a small pilot in Medway and then a wider pilot. And I think that on the days in question that the pilot was running, it was helpful, but we didn't see the impact on reduction in section 136s that we'd hoped to. But we've taken learning from that, and what we will be providing as part of the urgent and emergency pathway is from April, KMPT are being commissioned to provide a 1-hour urgent response to both CCAM and to Kent Police. So currently, as I explained earlier, there is a team called the 836 team, which is a team of mental health clinicians available 24/7, whom the police call when they are deciding whether or not to use their powers of detention. We are going to be expanding that service to offer a hear and treat service to both CCAM and Kent Police, whereby not only will we speak to the police officer or the paramedic, but we also will speak with the individual in question, and a decision will be made whether or not a see and treat response is required as well, and then we will be going out to see the person at scene within an hour of the referral being made.
And can I ask a further question? Fairly locally to me, there was a young man, obviously had issues, but he repeatedly kept committing the same type of crime. At what point is it decided whether and this person ended up in police custody and got a custodial sentence, which he needed to be taken off the streets, but it was obvious to anyone that saw him he had mental health issues. So how is it decided that they get arrested instead of getting locked up in a different way, so the public safeguarded, but get treated because, he was violent, so he had to come off the streets. It's hard to have sympathy for him, but when they've got mental health issues, putting them in prison isn't going to treat them. So how is that decision decided?
So within each police custody suite, there is access to mental health clinicians. So they're the, Jackie might have to help me here, the CJ lads. So the criminal justice liaison and diversions teams. So the police will make a referral to CJ lads, that's the acronym, if they believe that there is a mental health issue, and CJ lads will undertake an assessment and determine whether or not that person does have a kind of a mental health need, and sometimes the person will have a mental health need, but also will have capacity in terms of their behaviour, and sometimes they won't, and in those circumstances there are provisions under the Mental Health Act where somebody can be diverted through the health system rather than the prison system. And I don't know if Jackie wants to.
I think the other sorry, take your mic off. Sorry. Otherwise I echo, don't need me echoing. I think that the other element of it is from the advanced mental health practitioners, so AMPs. So if there's somebody that is in distress through their mental health, then actually we might go and complete a mental capacity assessment with the doctor to look at actually whether we need to consider sectioning somebody. So there's different routes that we work on together to try and stop people from going into the police stations, because as you say, it's not the right place for them to be. And there's a piece of work taking place at the moment that Louise is leading on called Right Care, Right Person, that will a system approach about how are we making sure that police are only intervening at the right times, because we know that sometimes actually a police officer turning up when somebody's in a really bad way with their mental health can actually cause further issues. So lots of different ways of trying to prevent that.
Thank you. Thank you.
Councillor Brake.
Thank you very much. Nice to see you again, and thank you for coming and subjecting yourself to the rigours of overview and scrutiny. I'll keep my question brief, and that is really that by way of background to say that what we've seen in Medway over the years has been completely diluted to us effectively having nothing. And you know, you're talking about, well, if we're lucky, we'll have a car in the car, police car in a car park to deal with individuals. The question is really, when will we see normal services being resumed here in Medway for the benefit of those here in Medway with mental health issues? And this is a question I will continue to ask until I get the answer that we all want, and that is normal service will be resumed on whatever date it might be. We have seen our mental health services decimated beyond all recognition. Today there are wards on Medway Hospital that were designated, they were actually built to be mental health facilities, to look to, so that people within Medway with mental health conditions could be cared for in the right way. Under KMPT, looking after a previous slide that we saw, they're talking about 18 million people, I think it is, being spread across, or 1.8 million people spread across the whole of Kent that are being looked after by KMPT. Yeah, they're all over the place, but here in Medway, we have sweet nothing. Nobody is really looking after those with mental health issues here in Medway. And that is a very sorry state of affairs. And every time this Overview and Scrutiny Committee raises its head above the parapet, every time Medway Council raises its head above the parapet, we are being kicked into touch every time. And I'm relatively new to Overview and Scrutiny, having done many years as a portfolio holder looking after this area. And believe me, it's a travesty that what we have. And I just want you to realise, travesty, that we have. And I think it's important that we all recognise that Medway does not have the services that we had in the past. We've been torn apart, and here we are worrying about how we're going to be looking after our people here in Medway. So please, when will we begin to see a return to normal services, please, Louise?
Can I just ask...
You know that I'm quite passionate about this.
Absolutely, I know that. What do you mean by normal services specifically?
Well, normal services where people with conditions here in Medway aren't going to be rushed out to Gravesend, Dartford, across to Maidstone, could finish up in Canterbury. When are we going to have a facility and a service here in Medway that will look at people here in Medway? Because it's well known and established, even by KMPT, that people with such conditions are better off if they're close to their homes and relations. Just so that people can understand where we've been. KMPT promised faithfully when some of the services were taken away from Medway and placed in Dartford and in Maidstone, that don't worry, we will look after the family, we will look after the individual, we will provide transport for families so they can go and see their loved ones. A hollow promise. One of many promises that have never ever been kept by KMPT. And I'm not blaming Louise for that situation, but it's the organisation that today she is here representing. And I think these are the questions that we got to put. We got to find out, when are our people here in Medway going to be looked after in the way that people who live in Dartford or live in Maidstone or live in Canterbury or East Kent, they're being looked at. When are looked after? When are our people here in Medway going to be treated in the same way, please?
So I guess my response to that is you're talking about acute inpatient facilities,
And
Sorry, Louise, it might be worth just explaining the services that are in Medway, so it's clear to everyone what we actually have at the moment.
Okay,
if
so
you don't mind, thank you.
Yes, you're right. Yeah.
So I'm not representing KMPT, just for the record. I'm representing the ICB, but I am thinking what exists elsewhere that doesn't exist in Medway, and certainly acute inpatient beds. There aren't acute inpatient beds in Medway, but Medway does have the same community mental health services that are available across Kent and Medway. So it has a community mental health team for both younger adults and older adults.
Sorry, Louise, it might be worth actually having an update that it gets circulated outside of the meeting so that you can answer the other questions.
I can certainly do that. I
That's
think
all
the
right.
point I was making was that I know that the move of the acute inpatient beds away from Medway caused considerable concern, and I understand that. What I want to say is that acute inpatient admission is a very small component of a much wider mental health provision, and actually the long-term plan, the NHS long-term plan, is about finding alternatives to inpatient admission. You know, we being admitted to an inpatient ward should be the very, very, very last resort, and so what we are doing is putting in provisions and alternatives to inpatient admission, and in fact Medway's the provision of a 5-bedded crisis house is coming to Medway, and we're not putting we're putting the first crisis house in Medway, and the first the Medway is the only place within Kent and Medway that have this 12-hour, 7-day-a-week safe haven co-located with Medway Foundation Trust, which will go live to 24/7 from April. So April next year, it went live for 12 hours a day, Friday just gone, and as I said, the crisis house opens in December. So I think Medway doesn't have inpatient beds locally, but inpatient admission is a very small component of a much wider mental health pathway, and Medway does have parity with other areas in terms of the mental health community provision.
And I think we all welcome the 5-bed crisis house as a way of prevention, avoiding of the beds. Can we move forward, Councillor Brake? Who's going to move forward? Right, Councillor Crozer.
Yeah, can you just clarify something for me, Louise? Thank you. I think when we spoke about this before, you were trying to reduce the number of people that were being sectioned wrongly, and the idea was that you had clinicians available to the police so that they could refer quickly to them. You mentioned just a few minutes ago about having a clinician in the police station. I didn't understand that was correct. I thought it was that they had access to clinicians 24/7 on the telephone that they could use to... So could you just clarify what you're saying there? Because it sounded like you were saying they were actually in each of the police stations.
No, they're not. No. So it's as you described.
And then the safe rooms are places where the police or the clinician that advises, that's where you take them.
Yeah, if the decision is that somebody does warrant detention under 136, then the police will convey to the Section 136 health-based place of safety, and the handover care to a clinician.
So essentially taking the decision to section it away from the police or to make it a little bit more robust by having a clinician
Yeah,
there.
to provide an alternative and to help and support the police officer on the front line.
Thank you.
Thank you, Louise. Any other questions, members? Councillor Cook.
Just a very brief one. It might be my lack of understanding, but my understanding is that it's the police that will be bringing these individuals to this centre. I really take what Councillor Brake said about impact on our wider services, and I think, we've spoken a lot about budgets, and I'm also aware that the police themselves are struggling, I know we're not specifically here to talk about the impact of the police, but looking at the risk register, one of the high impact critical risks we've got is impact on other partners of potential closure. But has risk analysis been done of the impact on the police of having to drive further, and then when they've finished, drive further to come back, and the impact that has for Medway in terms of those police officers then not being on the streets? Thank you.
So within the decision-making business case and the pre-consultation business case, you'll note the travel impact assessments that were undertaken, and actually we think there'll be a reduction certainly within ambulance time and I believe police time, because currently if a Medway resident is detained under section 136, officers currently will have to go to Canterbury perhaps or to Dartford. When we looked at the figures, I think about 45% of people detained under 136 were having to be conveyed to Canterbury. So the police are very much in favour of this, and yeah.
Thank you. I really appreciate that. I think that's if the comparison was Canterbury or Maidstone. I think we're all in the room saying we wish the comparison was a resident in Medway was taken to a place in Medway, and that Medway-based police officer could then get back on the streets in Medway. So I think that's just the point I'm trying to make there. Thank you. Thank you, Chair.
Okay, finally, quickly, Councillor Wilding.
Yeah, and again, it's more of a comment. I believe we should thank you for the successful bid. 3.7 million is not a small sum of money, and bids aren't always a matter of a phone call. They can be quite hard work. So thanks to you, and thank you to the government for providing the money. Thank you.
They provided the money, but after years of not providing the money, I'd like to say thank you as well for the bid. And thank you for answering all of your questions, all the members' questions, and thank you for coming, Louise. We'll move over to the Vice Chair.
I move that we note the decision made by NHS Kent and Medway to approve the decision-making business case and provide an update after the HBPOS has been open for a meaningful period of time.
Is that seconded? Agreed? Agreed. Thank you. Please. So we move forward to the last item, which is the work programme. Over to Michael.
Okay, thanks, Chair. Nothing to add, really, but happy to take any questions.
If I can.
Councillor Wilding.
Your favourite person. Can I suggest that it's put on the work programme that we look at the stroke provision for Medway and the latest update on the HASU hyperacute stroke units, because I believe one has opened after about 14 years of trying or something. Again, not in Medway, but in Maidstone, I believe. And I also think it would be a good idea that we had CCAM regarding their times, again on TIAs, which often present as strokes. Last time, the papers suggested, so I'd like an explanation, that call-out time was 90 minutes, which is totally unacceptable. And I would like that to be discussed at the next pre-agenda.
Yeah, you are due to have an update from CCAM. It hasn't been programmed in yet, so probably that information could be put into that report.
Yeah, but I do believe in the light of the TIA report, sooner rather than later, if the committee agrees and if Dan agrees.
We also have an update from the ISDN team.
Thanks, Chair. So I think what I'm hearing is you want an update as to the performance of the integrated stroke delivery network. Is it because I think referring, because Maidstone has been open all the time. So if you're looking at the new facilities that are built down there, that would be a slightly different thing. It's just about the facilities, but it has been operating as a stroke unit for since 2 2-3 years ago, so I don't think it's a new provision.
I did read somewhere that it is now regarded as a hyperacute stroke unit, but, you know, we can discuss this outside this meeting if you're happy.
It has been all the time since the stroke configuration.
So let's have a discussion about what you would like, and then it could be, if it is something that can be provided, everyone can be the recipient of that information. Does that sound okay to everyone?
Right. And can I, one further thing, thank you for stepping in as chairman. I know it's not as easy as people think, so well done.
It's been a privilege to be the chairperson this evening. Thank you very much, everyone, for your questions and behaviour. Should I say that? Thank you, Michael, for your support. I think we'll call that a close. Thank you very much. Oh, I beg your pardon. I've forgotten the recommendation. Over to you, Vice Chair.
I move that we agree the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in italic text.
Is that seconded? Agreed? Agreed. Meeting closed. Good evening.